Patient takes a deep nasal breath and there is a sort of sneezing sound, or the patient makes such a clearing of throat, that means there is something sticking, layering the throat. These all are symptoms where secretion is stuck in the posterior pharynx and the and the oropharynx, and these patients likely have the post-nasal drip. So these gives me clue for post-nasal drip. After that, I have a torch. I just put light into it. I like to see. Many times it has to be a little thorough. You see the upper part of the nose as far as you can see, and if you see all things are shiny, it is not always secreting, and the mucosa may be appearing absolutely normal. So from history, then a little bit of clinical examinations. You also ask the patient for sinusitis symptoms and just tap on the sinuses. Sometimes it is painful, sometimes not. And in history, one more thing is very important: the past history, the history of seasonal association, the history of cough with exposure to cold, or history of cough with exposure to some specific thing. It gives an idea that, well, it could be an allergic rhinitis kind of problem. And after that, I ask for just an X-ray of paranasal sinus, occipitomental view most of the time. And if I find there's thickening of the nasal mucosa, it is also very tricky because in clinical examination you may not find anything, but once you go for a X-ray, you find a lot of things. So, Dr. Is there?
Dr. Shah, may I ask you that when a pulmonologist refers a patient to you as a patient having frequent allergic symptoms, allergic rhinitis symptoms, so then how far you are going to investigate the patient and for your expert?
Respiratory infection or inflammation, patient is referred to me. The symptom with nasal obstruction and patient having one case of refractory epistaxis. Sometimes patient may present with hemoptysis, but the cause is obscure. Sometimes nasal intonation of voice. Patient presented with pulmonary tuberculosis with hoarseness of voice. Some patient presented with pulmonary tuberculosis, granulomatous lesion, but it is not the pulmonary tuberculosis. Biopsy shows patient having some granulomatous lesion due to sarcoidosis. I have got last 2 months back this patient. All this patient endoscopic examination together with biopsy is very important. Together with what I am thinking, I can show some slide.
Please share the slides. What sir want to show us. Sir, you can come. Slide down. Slide.
coming, for which collaborative opinion is very important. Now, what are the patients of pulmonologists referred to me? Here, specially patient was referred by Dr. P.S. Bhattacharya, and the patient with symptoms of difficult and refractory nasal blockage. Number. And another patient, that is patient with nasal intonation of voice, hemoptysis, snoring with or without sleep disturbance, hoarseness of voice, persistent cough, and choking sensation. All these patients having that symptom referred to me. Now, let us discuss the nasal blockage. This is two types, allergic and non-allergic. Again, allergic causing chronic rhinosinusitis divided into with polyp, without polyp. And non-allergic cause mostly anatomical factor, that is deviated nasal septum, enlarged turbinate, enlarged adenoid, and nasal tumors. Other than this, vasomotor-rhinitis and rhinitis medicamentosa is not so infrequent. Now, this is the picture. The patient enter anesthesia is done. There is polypoid mass in the nasal cavity. This is the endoscopic picture showing the polyp coming from the middle meatus, occupying whole of the nasal cavity, obstructing the nasal airway. Another is the terminate hypertrophy causing obstruction. This is the excess of tissue neck showing adenoid hypertrophy. And most common cause of nasal obstruction, we have seen that is the deviated nasal septum that should need surgical correction. This is the airway allergy, allergic rhinitis, and asthma is very closely associated. Now, this is the allergic mass, starting from eczema to rhinitis, food allergy, asthma. This is one-way hypothesis, same disease, different sites. Now, 42 to 60% of allergic patients having asthma, but compared to 12 to 15% of patients with asthma without allergic rhinitis. This is the findings, and this is the another some patient having rhinitis without asthma, but there is subclinical changes in lower airway, and that considered spirometric study to evaluate the case. Now, this is the patient having CT scan of eosinophilic chronic rhinosinusitis compared to non-eosinophilic chronic rhinosinusitis. It is found that the eosinophilic group, there is massive mucosal thickening in the sinuses. Now, I am coming this CT findings of mucosal thickening of nose, paranasal sinus in asthma with allergic rhinitis, and the CT of chest showing small area disease in asthma. Now, treatment part, it includes, diagnostic part includes allergic testing supported by radiology, supported by nasal endoscopy and acoustic rhinometry. Now, treatment is common restriction of the allergen, pharmacotherapy, immunotherapy, but with the ENT people concerned with this surgical indication, if there is deviated nasal septum and terminate hypertrophy that can affect the use of tropical steroid medication, for which it needs treatment. In case of nasal polyposis with irreversible mucosal disease, treatment is functional endoscopic sinus surgery. This we are doing. Now, let us discuss the nasal intonation of patient. Some of the patients referred to me with nasal intonation. Nasal intonation, nasal speech with the nasal quality, it is hyponasal, hypernasal. Hyponasal was the adenoid hypertrophy, allergic rhinitis, deviated nasal septum sinusitis, myasthenia gravis case, and terminate hypertrophy. But hypernasal speech usually hints cleft palate and velopharyngeal insufficiency. Now, we can see hyponasal speech associated with adenoid hypertrophy, terminate hypertrophy, hypernasal speech hints cleft palate and valopharyngeal insufficiency. Now, treatment causing nasal voice needs surgery. We are usually doing tonsillectomy, adenoidectomy, septoplasty, face, palatoplasty, and sphincter pharyngoplasty. But in every case, post-operatively, we are giving speech therapy. Now, let us discuss hemoptysis. Some patient presented obscure hemoptysis, coughing up of blood from lung, but bleeding from upper respiratory tract or upper digestive tract is not uncommon, and it is termed as pseudo hemoptysis. This is a patient of 60 years age. This patient suffering from posterior epistaxis simulating hemoptysis. But we have done nasal endoscopy, take biopsy. Biopsy came as nasopharyngeal carcinoma. The CT findings of this patient, again, this is another patient having 14 years male patient having recurrent profuse epistaxis, sometimes simulating hemoptysis. On examination of with endoscope, there is a vascular mass, and CT finding shows nasal mass, and that extends to the retromaxillary space. Clinical diagnosis is juvenile nasopharyngeal angioedema. Treatment is surgery. Now, let us discuss the snoring with or without sleep disturbance. Usually, we are doing CPAP, but for treatment, but especially ENT are expertise to both surgical and non-surgical management. The surgical indication when medical management fails. Another, the anatomical site of obstruction, if at the nose, palate, tongue, that should be corrected. Now, following at the surgery, we are doing for OSA, that's turbinate reduction, EPP, tonsillectomy, palatal implant, tongue reduction, genioglossus advancement, maxillomandibular advancement, hypoglossal nerve stimulation, but sometimes tracheostomy is in need. Now, this is a patient with snoring, child with or without sleep disturbance. This patient having snoring without sleep disturbance, and this is with sleep disturbance. Both patient underwent adenotonsillectomy. Following operation, patient symptoms improved, oxygen saturation improved, PCO2 decreased. Now, I am going to turbinectomy. That is endoscopic turbinectomy. We have done this for nasal obstruction. This is a mandibular advancement splint for OSA. Now, let us discuss the hoarseness of voice. This is a very common patient with pulmonary tuberculosis presented with hoarseness of voice. Patient was referred to me on endoscopic view. I've seen there is a lesion in the vocal cord, especially true cord with anterior commissure. A biopsy was taken, proved as tubercular lesion. This is the chest X-ray of that patient. Now, following treatment, what is the findings of larynx? Larynx becomes normal. Now, this is sometimes primary laryngeal tuberculosis is not uncommon. This is the endoscopic finding shows laryngeal lesion. This is also laryngeal lesion, biopsy taken, proved as tubercular lesion. Chest X-ray is clear. Following treatment, larynx comes normal. Again, this is a patient presented 2 months back. Patient presented with hoarseness of voice. I did fiber optic laryngoscope, see there is a mass in the larynx, and that was taken, and it came as non-caseating granuloma. There is sarcoidosis. Laryngeal sarcoidosis is this patient, and this patient after treatment, larynx become normal. Now, this is also another case of oral sarcoidosis of heart palate. Now, let us discuss the cough, persistent cough, very frequent complaint. Refractory cough, mostly apart from allergy, asthma, COPD, it hints sinusitis with postnasal drip, GRD, and vocal cord disorder with phonatory gap. Now, the endoscopy findings for GRD or LPRD, that is the congested vocal cord. Again, this is a patient having phonatory gap with persistent cough and postnasal drip. Now, last is the choking sensation in throat. Some patient presented with choking sensation in throat, and this patient usually involuntary contraction of larynx, vocal cord, together with this is temporary and usually occurs during extubation following operation. I take endoscopy of the larynx. This is the laryngeal spasm. Now, this is another picture showing larynx in postnasal drip. Now, coming to the conclusion. In common respiratory symptoms, collaboration between otorhinolaryngologist and pulmonologist is very important at times to help a patient. This is our institute where we are working. Thank you.
Thank you, sir. Thank you for an excellent and deliberate and detailed discussion. Now I welcome Dr. Shiva Reshmi Unnithan, who will be presenting on the adult vaccination. As we know, prevention is better than cure on every time. Now we are planning for the prevention. Sir has told about the cure. Now we will think about what are the preventive measures as a form of vaccination, and what is the present and the future of that. Please.
Very good morning. So we kick-started the program with a very nice discussion about the kind of coordination that we should have between a pulmonologist and the ENT surgeon. But this coordination should not end here. So my topic is at large. It's not just about vaccines. It's also about the incorporation of this immunization into our national program. So, which is why I think a much bigger and a larger coordinate effort is required. We start off, so I'm talking about the present and the future. I wouldn't start the presentation without one slide about the past. You see these three pictures. The first is Edward Jenner, who borrowed the information and the knowledge from the old world people that in India, Egypt, China. These people used to use inoculation programs, procedures for trying. He borrowed that information and used cowpox as smallpox vaccine. That's how he is the father of vaccination. Louis Pasteur started off with rabies vaccination, anthrax, fowl cholera, and he was the person who showed that actually almost all the infectious diseases can be prevented with vaccines. Hafkin I've mentioned in this because he's the important person in our country. He was the first person to start the plague vaccine. That was the first vaccine in India. Now we know India is a young country. That's what we know at present, that almost 5% of our population are within 35 years. But in the next few years, as you see here, as we go towards 2030, 2040, the age is going to decline. Rather, the youth category is going to decline. We are going to have more of adults, above 45 years age, and that is to the tune of from 18% it's increasing to 40%. That is what we are projecting by 2050. So that means almost every third or the fourth Indian will be above 45 years, and that means that is a huge potential population who are at risk of these diseases, vaccine preventable diseases. Influenza, typhoid, pneumonia, MMR, diphtheria, pertussis, tetanus, meningococcus, HPV, varicella, hepatitis, COVID. I've included COVID because this is just, we have seen the entire pandemic, and herpes zoster. So these were the diseases that were recommended by different organizations, different societies, not particularly by the Indian government. Just to show you why we have been talking about so many diseases, influenza, pneumococcal disease, hepatitis, measles and rubella, typhoid, these have shown in the past few years to cause morbidity, and in some cases, especially in pneumococcal infection, when you have invasive pneumococcal disease, you are talking about mortality. So these are, and of course, these diseases like influenza and hepatitis, they are indirectly increasing the mortality in our adults. In the last, from 2016 to 2017, this was a literature review that was done, and you see this epidemiological shift in the affected age groups. You see a lot of, you do see a lot of influenza and pneumococcus, but you see diphtheria, varicella, and meningococcal diseases, measles. These are also causing a sort of an endemic situation amongst adult population. Why is vaccination so critical? We are trying to protect our elderly because their problem is not just in their system itself, but also the political situation. Vaccination was implemented in India pretty late, in 1978. So we have a good number of Indian adults above 50 years who have not been either vaccinated or are incompletely vaccinated. Along with that, you have immunosenescence. With age, there is deterioration in the function of the immune system, which causes the person to be highly susceptible to infections, neurodegenerative, cardiovascular and autoimmune diseases. That is again causing them to be a sitting duck for different kinds of infectious diseases, and you are seeing an increase of threefold mortality rates in this. Then there is this concept of inflammaging, subclinical infection with increasing age. So you are actually increasing the possibility of chronic diseases, diabetes, chronic lung, heart diseases, kidney diseases. These are all because of inflammaging. This is one concept that we have come across. So now you see, infections are the leading cause of death in 30% of our elderly patients. Now this infection is further aggravating the underlying diseases that they have. And you are also seeing functional capacity reduction. Not just lungs, you are also seeing functional capacity of the entire body. All this modification is leading to new infections, endogenous injuries, and there is reduced immunity to previously encountered pathogens. Now, we are also dealing with emergence of antimicrobial resistance. So maybe with vaccines, if you can prevent this typhoid or pneumococcal infections, at least some part of this antimicrobial resistance can be countered. So COPD, diabetes, asthma, smoking, all independent risk factors for pneumonia. There is an extra layer of defense that is required for our diabetic patients, which is why different kinds of vaccinations have been propagated for our diabetic patients. poor antibody response. Overall, there is a reduction and there is an immune dysfunction. And you see increased susceptibility to hepatitis, increased susceptibility to HIV. So it's not just influenza or pneumococcal vaccine that we are talking about in our diabetes patients. There are many more vaccines that are required in them. When Gold Guidelines brought out this particular slide in their into 2023 guideline, we were pretty excited because we thought that now influenza, pneumococcal vaccination is so this is now going to be a propagated vaccine. But along with that, COVID-19 has also been included, Tdap, especially the pertussis part. As I said, there is an epidemiological shift in the age groups. So now we have to think about pertussis, we have to think about diphtheria, we have to think about herpes zoster, and we have to think about measles in our as pulmonologists, in our chronic lung disease patients. So I come back to pneumococcal disease. Invasive pneumococcal disease we thought was a sort of a exotic kind of a disease, but no, this is associated with high case fatality even in India, and where we know that more than 80% of this invasive serotypes, they can be managed with the polysaccharide vaccine. This is something if we should help our respiratory patients. Pneumococcal conjugate vaccine, these two, the Capita study and Louisville study, this actually helped us to help our patients with the particular pneumococcal conjugate and the polysaccharide vaccine. I'll talk about the schedule in the next few slides. API went a step further by asking, actually ACIP had, CDC wanted this vaccine, the pneumococcal vaccination above 65 years. But API in India wants these vaccines in adults above 50 years. Primarily because we started a vaccination program in our children much later, and therefore the herd immunity is much lesser in India. So that is why they want this kind. It's not yet in the guidelines. So this is the kind of sequencing we want in our adults for the pneumococcal vaccine. If there is no history of pneumococcal vaccine, first give PCV13, produce immunological memory, which this conjugate vaccine actually does, and then it is followed by PPSV23 as the booster. Those who have already received a dose of PPSV23, where most of our COPD asthma patients do, if they have already received it, then just wait for a year and then give the PCV13. If you want to give a booster dose, then you will have to wait for another 4 years. That is, from PPSV23, you are going to give 5 years later. In our immunocompromised patients and those with immunocompetent patients with chronic conditions, you don't need to wait for 1 year. After your PCV13, you can give your PPSV23 after 2 weeks. You can give your influenza and pneumococcal vaccines together at the same visit, which is very convenient. And but for your COVID-19, you'll have to wait for 2 weeks. If you give your COVID-19 vaccine, then after 2 weeks, you must give the other vaccines. I come to flu. Flu, you know, is, in fact, I just suffered flu a few days ago, and that is why you hear this bad throat. Influenza is globally, it has an annual attack rate of 5 to 10% in adults and 20 to 30% in children. So there are different types of influenza vaccine infections, seasonal, where you have these peaks, and then the avian and the swine variants. Pandemics are caused by a completely different variant, which may be a mutant, and usually an influenza A. It can happen in all age groups, it can happen all throughout the year, and usually any of these avian, swine, or maybe other influenza variant. So this is the kind of peaks that we usually see in India. in the March, April, and in August, October. So this is a relatively older data. This is from 2010 to 2013, and there was another study that came in 2015 which told us that there are different areas, different pockets of in the country that have different seasons. So it's not that the whole of India has a peak in March, April and a peak in August, October. Our part of India, eastern part of India, western part of India, we have our peaks from June to September. So it's very important that we now rethink the timing of our vaccination for the influenza vaccination of our adults. Probably April, May will be the right time for all the adults who stay here in whom we are catering to. Ones who are in South India and in Jammu and Kashmir, they face the peak season at much later in the year, from October to December. So they might do well if they are getting their vaccine somewhere in September, October. In India, from 18, any adult up to 50 years, it's the decision of taking an influenza vaccine is completely up to discretion. Doesn't matter whether you have comorbid conditions, you don't have comorbid conditions. If you want, you can take. More than 50 years, you must take. Annually, you must take. In fact, ACIP is asking for influenza vaccination in anyone more than 6 months of age. Now, there are different societies, different organizations that have tried to propagate this adult immunization since 2015. Even Indian Chess Society has tried to chip in. 2021, API tried to bring out a very comprehensive list of the vaccines that should be given to adults, but still we have not been able to include it in our national immunization program, just like ACIP has done for USA. This is an excellent the immunization schedule, and it's mostly for the ones who are not normal, like immunocompromised patients, HIV patients, asplenia, end-stage, all kinds of comorbid conditions, chronic conditions. Then diabetes is also there. Now, healthcare personnel have also been included in the immunization schedule, which is very, very important, and I believe that is the right way to go forward. What are the barriers? What are the barriers and opportunities where we can try and help our older adults get their immunization? So, older age, there is a discrimination, there are cost issues. Maybe if we can increase the cost, reduce the cost. There are missed opportunities to vaccinate. Vaccine access is not there. Vaccine hesitancy is there. Most of our healthcare professionals are not even aware about vaccines. Even if they are aware, they forget. It's not part of their schedule, it's not part of their prescription. There is absence of national guidelines, and you have an inadequate surveillance system. This is API guidelines which they have, please look it up, it's an excellent way. They have tried to amalgamate all the vaccines, and they've tried to put in the right situations where your vaccine should be given. But it doesn't help if these kinds of celebrities come into this anti-vaccination campaign. In the early 1900s, these were the kind of cartoons that were put up as anti-vaccination. And then you have this man, Andrew Wakefield, who started talking so much about the MMR vaccine causing millions of children having autism. His medical degree was removed. He was bereft of his medical degree, but he went on to make a documentary, Vaxxed. And there are plenty of people, especially in the West, where they are absolutely passionate about anti-vaccines. In India, vaccine hesitancy is a pretty very common thing. Religion, gender, political ideology, trust in medical and scientific institutions, the mistrust as I would say, socio-economic, racial inequities, safety concerns, especially when COVID-19 vaccines came in, there was a big suspicion towards new vaccines, how the pace in which the COVID-19 vaccines were developed and just granted approval for human use. They thought that we were being guinea pigs. Even most of us, even the medical professional, we thought that we were guinea pigs. Limited data about the safety of vaccines, rumors, misinformations on the social media, all this is influencing the vaccine hesitancy. And look at this COVID vaccine. See, this is the hesitancy graph that you can see. Thankfully, West Bengal, Delhi, we were less hesitant about vaccines. Whereas, look at Nagaland. There were 45% people who were hesitant about vaccine. Vaccine uptake in India is so less, just 2% for each of the vaccines. It's higher in older adults, those who have more years of schooling, chronic diseases, those who are wealthier, but you can see what number of patients, percentage of population actually are there. So this is, in spite of all the vaccine hesitancy, this is, you see, at least one vaccine of COVID. There was almost 100% in almost all the states. And fully vaccinated, very nice, at least above 75% in all the states. So we are quite prepared. Our healthcare delivery system cannot be more better prepared than what we have today for adult immunization. We have the COVID vaccination centers which can be changed to adult vaccination centers. Trained staff is there. Cold chain equipment is ready. We have the electronic vaccine intelligence network where we all used to receive messages whether we have taken our vaccines. We have the adverse event following immunization monitoring, which we call AFI monitoring. All of us have been asked about the different side effects that we may have come across. So the roadmap to improving adult vaccination is coordinated adult immunization program, ongoing assessment of immunization rate and workflow with close follow-up. You use your clinics. Clinics can use the vaccination, try to maintain the records. Awareness among the patients as well as physicians should be there. Use your patients when they come for their visits, regular visits. Use those regular visits to give them the adult vaccines. Make the vaccines more affordable and target the high-risk occupational groups first, just like what we did for COVID. Just target the high occupational groups first, food handlers, healthcare professionals. Once they see that they are fine, then that is when they will be able to propagate to the next population. And I finish off with this slide where if leaders like this are in the anti-vaccination campaign, probably you are on the right path when you are advocating vaccines. Thank you.
Thank you, Dr. Shivarasmi, for an excellent presentation. We all had been enlightened with your present status and the future program, and we will definitely take steps to involve these in our national immunization program. Now we have 2 more lectures, then we will have an expert panel opinion, and I would request the speaker to please stick on their time. Next, may I invite Dr. Raghav Raoji, who will deliver his lecture on the bronchiectasis schematic evaluation. Welcome.
A very good morning. Thanks for this wonderful opportunity to speak here. The topic for my discussion today would be bronchiectasis and schematic evaluation. Bronchiectasis per se, we all know, is something which is associated with cough and sputum production, which is characterized by abnormal thickening and permanent dilatation. This per se is a definition, is an end result of a disease. It's not a disease per se, but a heterogeneous group of diseases of different etiologies. So when we try to evaluate what the cause of bronchiectasis is, what is it we are finally achieving it? Is it really going to change our patient treatment, or is it at the end we are just going to glorify giving some fancy name? Definitely when we are trying to evaluate the cause for bronchiectasis, we identify some specific cause. And in this pursuit of identifying a specific cause, we find treatable traits and specific therapies, considering cystic fibrosis bronchiectasis, where we have some really good medicines. Then ABPA, wherein the treatment would be steroids and azoles. Similarly, when we have immunoglobulin deficiency associated bronchiectasis, we treat them accordingly. So all of these are definitely treatable traits, and thus put forward a point in identifying the specific cause for bronchiectasis. In spite of all this, even if we end up having bronchiectasis wherein we really can't treat them, at least our patients want to know what the cause of illness is. We'll be able to tell them what their disease is, and they can have genetic counseling and family planning things planned for. So diagnosis is essentially by HRCT, which is a gold standard for bronchiectasis, and all the different signs which are described for bronchiectasis are as a result of damage and dilatation of these bronchial walls and mucus plugging. But what is also more important is to understand what is not bronchiectasis. What is traction bronchiectasis, which we frequently encounter with ILD patients. What is pseudo-bronchiectasis, wherein we might confuse them with cysts or honeycombing. And post-TB bronchiectasis. I mean, it's a point of contention or debate if you have to call this as post-TB bronchiectasis or CPA. But whatever name you call it, treatment is again very important here. Maybe azoles would be the treatment of choice when we diagnose them with CPA. Sometimes bronchiectasis per se might be very subtle. Like here, we are able to just see some areas of subtle bronchiectasis, and in these cases, ancillary CT findings would really help us. Ancillary CT findings in the form of airway involvement, peribronchial thickening, centrilobular nodules, mosaic perfusion, all of these would really help us in making a diagnosis of bronchiectasis. The list of bronchiectasis is never ending, starting with airway abnormalities, congenital disorders, cystic fibrosis, primary ciliary dyskinesias, cartilage deficiency disorders, and the list just goes on and on and on. So when we try to evaluate the cause of bronchiectasis, we need to have a very systematic approach. Otherwise, we would just be lost in this pursuit for identifying a cause. So further to investigate, do we order a set of panel of investigations? Probably that's not what we are taught it. And it would depend on the characteristic presentations. First and foremost would be to see if they are focal or diffuse. Then the age of onset. Consider a child who's having symptoms of bronchiectasis, sinusitis from childhood. Our mind would be inclined to diagnose something like a genetic cause of ciliopathies, or someone who's having recurrent childhood infection, who had a history of significant childhood infections. There we would think of post-infectious bronchiectasis. Somebody having significant systemic symptoms, malaria, fever, weight loss, there we should probably be thinking of NTM-related bronchiectasis or post-tubercular bronchiectasis, ABPA, and so on. In people who have infertility and sinusitis, again, our thought process would be towards ciliopathies, GI symptoms, IBD-related bronchiectasis. So in short, if you have to really work up a case of bronchiectasis, I would probably characterize them as focal or diffuse. And in cases of focal bronchiectasis, next would be to look for any endobronchial obstruction, post-infectious causes of bronchiectasis, a sequestration, McLeod syndrome. Here the choice of investigation would be radiology, obviously the first step, and then flexible bronchoscopy to see for any endobronchial obstruction, or a CT pulmonary angiography for McLeod syndrome. If we have a diffuse bronchiectasis, I mean the place where I came from, we used to order the first step of investigation would be Aspergillus fumigator specific IgE to check for ABPA. And after that, immunoglobulin profile, mycobacterial cultures for NTM, and sweat chloride test if you have access to it. Depending on this diffuse bronchiectasis, if you have access to sweat chloride test, that is the best possible way. But many of us really don't have an access to sweat chloride test. This is where we really need to move on. And at the place where I work presently, I do not have access to sweat chloride. We move on to CFTR gene mutation analysis, or a PCD, is a primary ciliary dyskinesia genetic analysis, extended gene analysis. Following these two, we also get a tracheal electron microscopy mucosal biopsy to see for ciliary structure. At the end of all of this, if we still really are not able to diagnose, this is when we give a label of idiopathic bronchiectasis. So coming to in a short, for the etiological test, A basic minimum recommendation would be an Aspergillus fumigatus specific IgE, sputum cultures, immunoglobulin levels. To diagnose CVID, these have to be done at least twice, 4 weeks apart, and the lower limit should be at least 2 times below the standard deviation. Sweat chloride test, if you have access to, and probably the most debated thing is a post-TB bronchiectasis or CPA. I mean, whatever name we try to give it, we need to do an Aspergillus fumigatus specific IgG over there and treat them accordingly. At the end of all of this, I mean, there are 2 main registries which are presently published from India. One is from Rajadas's and the other from the PGI, EMBARK group. If you look, there are a lot of similarities and a lot of dissimilarities over here. I mean, the post-TB bronchiectasis is to the tune of 35% from both the registries. But what is more striking here is the percentage of ABPA from the PGI registry, which is to the tune of 42%. And both of them have, even after all this evaluation, they have an idiopathic bronchiectasis to the tune of 20% from the EMBARK group and around 15% in the PGI group. And there are certain pitfalls with the EMBARK registry over here. I mean, of all these 2,195 patients, only 388 were tested for Aspergillus ABPA over here. And all the others, they were not tested. Maybe if all of these had been tested, we would have had much more cases of ABPA. And the standard guidelines, ERS guidelines, were followed in just 3% of all these 2,100 patients by the EMBARK registry. Whereas all the 450 patients in the PGI registry had all the investigations done according to the ERS guidelines. So just to go through certain cases, this is the case of right lower lobe bronchiectasis, a focal bronchiectasis. I mean, if we further go through, there's a big tumor which is sitting, and then in the bronchoscopy, there it was a carcinoid. He went for a surgical resection. This is a case of, again, focal bronchiectasis in the left lung. He had a left hypoplastic pulmonary artery. The normal left pulmonary artery is more prominent than the right pulmonary artery, and this was a case of McLeod syndrome. A CT which was showing mucus plugging in the right upper lobe. On the mediastinal window and non-contrast window, this was diagnosed with HAM. The Hounsfield units were more than that with the paraspinal muscle. This was a very interesting young female which we had, who had a recurrent history of infections and was diagnosed with bronchiectasis. After all the initial tests, which were turned out to be negative, her immunoglobulin levels were very low, and she's been diagnosed with CVID-associated bronchiectasis. She is on regular monthly replacement of immunoglobulins right now. This is a case of post-TB bronchiectasis, or I don't know to call as CPA. Definite bronchiectasis is there. Aspergillus specific IgG was positive, currently treated with azoles for 9 months and is doing fine. This was another destroyed lung post-TB sequelae with NTM and presently undergoing treatment. And this is another very interesting case. This person presented after almost 5 years of the initial presentation. Initial presentation had left lower lobe pneumonia. Again, if you are able to see this thing, it's the left lower lobe have almost a very small part. This was actually a sequestered lung which was identified on angiography, and he again went for a surgical resection. The final case is probably when I was doing my residency in PJ, probably the most interesting case of bronchiectasis I came across. This is with the courtesy of my teacher, Dr. Inderpal from there. This was a young female who had bronchiectasis, predominantly in the lower lobes, characterized with significant centrilobular nodules, mucus plugging, peribronchial thickening, and pansinusitis. After extensive evaluation upfront, I mean, these were all the initial tests which we used to do for bronchiectasis serially. After all this battery of investigations, the main abnormality which was noticed was an increased sweat chloride level. So, obviously, with an increased sweat chloride level, the suspicion was of cystic fibrosis. However, CFTR delta 508 was negative. Then went ahead with CFTR gene mutation analysis. And to everybody's surprise, this was normal. There was no abnormality. This was when we had to actually go ahead with the next step, which would be a whole exome sequencing for primary ciliary dyskinesia. This threw up two abnormal genes, and both of them were of uncertain significance. Again, we didn't have an answer. This is when we went ahead and did a tracheal mucosal biopsy. And just to recollect, a normal cilia on an electron microscope, we have 9+2 microtubular arrangement, the peripheral 9 and the central 2 axonium structures. So this particular individual had compound cilia to begin with, and there was a disturbed 9+2 microtubule arrangement. The central axonemes were disturbed over here. If we are able to appreciate this over here, the central axoneme is disturbed, and a further higher magnification, there was a missing outer dyneema. So definitely at the end of all these investigations, we could diagnose her with primary ciliary dyskinesia. And the genetic mutations which she had, the DNA1 is associated with absence of outer dyneemams, and the high sweat chloride levels which were initially thrown up on her investigations were because of this another mutation which she had. Subsequent follow-up of this person, her younger brother also has bronchiectasis with a similar gene, and both the parents were a heterozygous mutation. So they passed on it to both of their children eventually. So as a take-home message for diagnosing bronchiectasis, we need to follow a very systematic approach. A minimum basic investigations should be based on focal or diffuse bronchiectasis. For diffuse, it would be at least an Aspergillus-specific fumigatus IgE, immunoglobulin levels, mycobacterial cultures. If these are really inconclusive, you can really go ahead with CFTR gene mutation analysis or extended gene analysis for primary ciliary dyskinesias in cases of suspected ciliopathies. Thank you.
Thank you, Dr. Raghavji. It was an excellent presentation from your institute. Now I would request Dr. Kanishka Kumar, who will be presenting on the exercise test in pulmonary practice. Welcome.
Good morning, everyone. Thank you, Pulmocon, for having me here. I am Dr. Kanishk. I work in Metro Center for Respiratory Diseases in Noida. And today we are going to talk about exercise test in pulmonary practice. This is not a very new test which all of us do in some form. Not all the exercises test is done at every center, but I know that everybody is doing at least some of it. I'm just going to discuss what are the most common exercise tests and how it is going to influence your pulmonary practice in terms of diagnosis of disease, which the cause of dyspnea, where the cause of dyspnea is hidden. So talking about exercise test, it is the quantification of cardiorespiratory fitness and for identifying mechanism of underlying exercise intolerance, particularly with regard to the activities having a significant aerobic energetic requirement. Now, what are the different types of exercise test in the pulmonary practice? The most common, which we all do at all centers, are the 6-minute walk test. The second one is shudder test. Exercise test can also be used to diagnose asthma, in which you have atypical symptoms or only 1 or 2 symptoms are there and the spirometry is normal, so can be used for the bronchoconstriction also. And the last one is the cardiopulmonary exercise test. Very few centers have it and the mastery on it. We'll be talking about few points of cardiorespiratory exercise test, cardiopulmonary exercise test in the later slides. So talking about the indications of exercise test in pulmonary practice, which goes for almost all the tests which we have discussed in the previous slide. That is the evaluation of the exercise intolerance, evaluation of unexplained exertional dyspnea when the patient comes to you and after doing a certain test you are not able to diagnose the cause of dyspnea. Evaluation of patients of cardiovascular diseases, CPET will be a helpful tool. Of course, the 6-minute walk test also can help you in that. And then evaluation of patient of respiratory diseases, in terms of the patient is having COPD, interstitial lung disease, pulmonary vascular disease or cystic fibrosis. It is used for pre-operative evaluation also, and evaluation for the transplantation and lung volume reduction surgeries. Nowadays lung transplant is increasing day by day at many centers. I think Chennai is doing very good in that. So all these tests help you to plan the patient for the perfect timing for lung transplant, pulmonary rehabilitation, and of course the diagnosis of impairment disability. Now we will be talking about the most common one, that is the 6-minute walk test. As we all know, that is a simple and safe test with low complexity, in which you would just have to tell and guide the patient to walk in a straight line in a corridor, And it's a self-paced test. Patients are asked to walk as far as possible in a 6-minute long time along the flat corridor. The distance in meter is recorded. Earlier it was recorded on a piece of paper. Nowadays I've seen people it can be recorded on the laptop or a tablet also. The standardized instructions and encouragement are commonly given to the person who is giving the test. But when you do the test, there should be an emergency plan that the need of oxygen requirement might increase in some patients. And the portable supplemental oxygen, if required by the patient to perform the exercise test, needs to be carried out. And the clipboard with reporting sheet and pen, of course, that should be there to record the distance, or can be done on the tablet too. Pulse oximeter and stopwatch are the two things which are required at that moment when you do the test. The normal distance is 400 to 700 meters in a normal subjects. How do you do the test? I'll be talking about it very slowly, and we'll be going step by step. Again, there should be a flat, straight corridor, 30 meter in length. Turn around points marked with a cone, so that the patient knows where to take our next turn. Patient should wear comfortable clothes and shoes so that he can walk very easily. Patient rests in chair for at least 10 minutes prior to the test. There shouldn't be any warm-up before the test. He should be completely relaxed, or she should be completely relaxed. Heart rate and pulse oxygen saturation should be monitored throughout the test. If there is a fall in saturation or the increase or decrease in heart rate, then you have to be very cautious. As I discussed, there should be an emergency plan all the time. If the patient is using supplemental oxygen, record the flow rate and type of the device, because different devices have different flow. Have patient stand and rate baseline dyspnea and overall fatigue using the Brog scale. Set lap counter to 0 and the timer to the 6 minutes. Instruct the patient. Remember that the object is to walk as far as possible for 6 minutes, but you don't have to run or jog. So the clear-cut instruction should be given that we are going to measure the distance and you have to give your best to walk for the proper time of 6 minutes. So standardized encouragement statements should be provided at 1 minute intervals, such as you are doing well, so that you get connected to the patient and the patient is very well motivated enough to complete the test. You have as many minutes left to go, and keep up the groundwork. Some kind of encouraging words in your own fashion you can say, just to encourage the patient so that there is a proper communication going on. At the end of the test, mark the spot where the patient stopped on the floor. If using a pulse oximeter, measure the pulse rate, saturation, and record everything. After the test, record the Brog scale of dyspnea and fatigue. Ask what, if anything, kept you from walking further if the patient stops beforehand. And calculate the distance walked. As we discussed, that 400 to 700 meters are the normal time. So you can take the picture if you want. Okay. Before moving on to the test, we should always know when not to do this test. And when not to do this test, mostly will include the cardiac causes. The causes which are very much essential for us to know when to not do the tests are acute myocardial infarction within 3 to 5 days, unstable angina, arrhythmias, endocarditis, pericarditis, and aortic stenosis. And when we talk about the respiratory causes, they are uncontrolled asthma or severe asthma, and the patient cannot walk at that particular moment. If the patient is having pulmonary edema, or the room air saturation is less than or equal to 85, that's also not indicated. And the patient is having acute respiratory failure, or there is an infection or renal failure or thyroid toxicosis in the patient at that particular moment. If the patient is mentally impaired and could not comprehend what's going on, then also it's very difficult to do the test. Relative contraindications including the stenotic valvular heart disease, coronary stenosis, tachyarrhythmias, bradyarrhythmias, electrolyte imbalance, or any orthopedic impairment that prevents the patient from walking. So of course at that particular moment you won't be able to do the test. So what is the clinical use of the 6-minute walk tests? The clinical use where we apply all these values to understand the type of the disease and how this 6-minute walk test is helping in the outcome or prognosticating the patient or survival time of the patient. So in COPD, it's used, 6-minute walk test is used in the board index, as we all know. As the point goes higher in the board index, the increases the risk of death in that particular patient. So 0 points is for more than 350 meters, 1 for 250 to 349 meters, 2 points for 150 to 249 meters, and 3 points for less than 149 meters. So as the point increases, board index severity increases, and as the board index scores increases, the probability of patient's death also increases. In IPF, in a prospective observational study of patients with newly diagnosed IPF, the 6-minute walk distance less than 72% predicted was a significant independent predictor of mortality with a hazard ratio of 3.27. That hazard ratio should be less than 1, but if it is less than 72% predicted, then its ratio increases up to 3.27. Also, it was seen in INSPIRE clinical trial that the 6-minute walk test less than 250 meter was associated with 2-fold increase in the mortality at 1 year, and a deadline in walk distance by more than 50 meter at 24 week was associated with close to 3-fold increase in mortality at 1 year. So all these data are there. I have shared the link below. It was the study which was published in 2018. Talking about the lung transplant, earlier in 2005 when it was started, the clinician used to put the patient first because they were not knowing about how much time it will take. The wait list time was very high, and there was a rush among all of them to put the patient for the lung transplant first. So 6-minute walk test helps you to understand the criteria to fit the patient wait list can be modified according to that. So for IPF, criteria for listing include desaturation less than 88% on 6-minute walk test, or 6-minute walk test less than 250 meter, or a decline by more than 50 meter in last 6 months of the patient. And if you're putting a patient of COPD for a transplant, then of course board index will be helpful. So all these things are evaluated, and 6-minute walk test play a big role to analyze the patient when to put the patient on transplant. Talking about PAH, the meta-analysis of 16 randomized controlled trials in PAH was done and confirmed the association that a 6-minute walk test was associated with the mortality of the patient when it was less than 330 meters. In European Cardiology and European Respiratory Society guidelines also says that PH is still, in PH we have to do the 6-minute walk test at the interval of 3 months to 6 months for the initiation of treatment. Now next walk test is incremental shuttle walk test. It is of 2 types, incremental and endurance shuttle walk test. Here, like an athlete, when the athlete runs at in the shuttle run, the athlete increases the pace. But here we are just not telling the patient to run, but yes, to increase the speed of the walk. So it's a 12-level test in which the subject walks at a progressive increasing speed for 12 minutes over a 10-meter course, where each 10-meter strip between the cones is one shuttle. So the cone should be placed at 9 meter. So 0.5 meters the distance is covered when you take a round of that cone. So the walking speed increases every minute from an initial 0.5 meter per second to 2.37 meter per second at the level 12. Stopped when the patient is having a lot of dyspnea, or the heart rate is more than 85% of the predicted maximum, or is unable to maintain the required speeds, or has completed his 12 levels. Then you can tell them to stop. Correlates with the peak oxygen uptake in patients with COPD and cardiac disease, which is the VO2 max. Improvement of 47.5 meter in COPD is slightly better which was published in 2008, and improvement of 78.7 meters suggests a better response to the drugs which the patient is taking. It can be also used as a screening test in the pre-operative assessment for the patient of lung resection or lung cancer, which should be more than 400 meters. The second part is the endurance shuttle test. Here you do not increase the pace of the patient. Here you increase the time duration of the patient walking. So it's an endurance test. So what should be the speed of the walk? It should be 85% of the maximal capacity measured from the incremental shuttle walk test. So ISWT has to be done first, and 85% of its speed should be done in the endurance shuttle walk test. The subject walk until they are too breathless, too tired, or no longer able to maintain that similar pace. Generally, the test stops at 20 minutes. If the subject is still walking at that time, then also you have to tell them to stop. The primary measure tool is the duration of the time which the patient has walked at a constant speed. So this is the endurance shuttle walk test. Now moving on to the next test, which includes exercise as a diagnostic tool, which is asthma. If the patient is having atypical presentation where the spirometry is normal, or the patient is having there's one or two complaints not clearly suggestive of asthma, then you can use bronchoprovocation testing. And bronchoprovocation challenge triggers can be of different forms, but here we are talking about exercise. So it can be cold air, histamines, methacholine. So we all know about it, but in exercise, we have to tell the patient to either do a treadmill, or the patient can do a cycling also. So if there is a fall of FEV1 of 15% after you tell the patient to complete the patient has completed the test, that is very much diagnostic of asthma. Even the value of 10% is suggestive of asthma in the bronchoprovocation testing, including the exercise. Now coming on to the last one, that is the cardiopulmonary exercise testing. This is something which needs to be talked about in very much detail, and it will take around it takes around a day to even talk about cardiopulmonary exercise testing. But this is a test here you can see in the photograph also, that the patient needs to just cycle it, and all the parameters will be displayed on the monitor which is there beside. And all these factors which we calculate help us to guide that the patient is having a cardiovascular system problem, or if there is a ventilatory defect, or there is a metabolic issue, or if there is a deconditioning in the patient, or the breathlessness is because of the obesity. So we are doing this test just to have to rule out some diseases and to get a perfect cause for the shortness of breath when the patient is coming to your OPD. So indications is very much essential, because in this case you are telling the patient to do cycling, and you are constantly increasing the load also. So you need to understand when not to do these tests. So because at our center, whenever we do cardiopulmonary exercise testing in Metro Center for Respiratory Diseases, at least one of the residents or a doctor who is very much aware of the ECG findings, they all stand beside the technician when the tests are being done. So this should be done in a proper monitoring is required. Yeah. So indications are the undiagnosed exercise intolerance, which is dyspnea, fatigue, assessment of exercise tolerance in patient with known pulmonary or cardiac disease. You have already diagnosed, but you want to assess it. Pre-operative evaluation for lung resection, and assessment of impairment of disability claim. Contraindications is very important, which is uncontrolled hypertension and arrhythmia. So we have talked about the contraindication of the 6-minute walk test. More or less it will be the same here. Angina, myocardial infarction, pulmonary embolism, poorly controlled asthma, all of these were there, but I still needed to highlight it, because when you do CPET, you have to be very clear that you can't do that test, because it is more demanding than the 6-minute walk test. So you get a report like this of 9 panel. Won't be going into much detail of that, but the first 3 graphs represent the metabolic and cardiovascular response. The middle row represents the ventilatory and gas exchange response. and the bottom line represents the mechanical response. So how do you approach a patient of dyspnea during the after the CPET test evaluation? You have to check for the VO2, which is the maximal oxygen which the patient has used, which should be more than 85% of the value. So if the patient has done that, then it argues against a cardiopulmonary or metabolic cause of the exertional dyspnea. Now you assess the efforts. If the patient is not able to get onto the VO2 of more than 85% predicted, then you have to check for the respiratory exchange ratio, which should be more than 1.16, or the heart rate should be 90% of the predicted. Now coming to the assessment of the ventilatory response, you have to see the maximal voluntary ventilation, which is MVV, and peak exercise, which is the VE max. And when you have a value of VE max upon MVV 30%, then indicating of ventilatory response to the exercise. Now when you assess the cardiovascular response, here you have to see that there is a low anaerobic threshold. I have also put a chart where all of these will be indicated, and there will be low O2 pulse with an early plateau. Here you can see in the diagram that the green line which is there represents the normal patient, and when you plot a graph of VO2 upon heart rate against time, then the patients having a cardiovascular disease, there will be a time where you reach a plateau very soon as compared to the normal individuals. Gas exchange, there will be increase in the VE by VCO2 slope, lower PET CO2 at rest or anaerobic threshold, or lower O2 uptake efficiency. And in the peripheral cause of dyspnea, if there is a peripheral cause, then it will be normal or near normal VE by VCO2 slope, or the PET end-tidal carbon dioxide. So it's very difficult to remember, but if you keep doing it, then it becomes a habit and practice, and we tend to diagnose it very frequently. So this, whatever we discussed in the CPET, all these measurements are there on the left side, and against all these diseases, all the values will be increased or decreased is written. So you can see in the heart failure, the anaerobic threshold, as we discussed in the previous slide, is decreased, the O2 pulse is decreased, and in diseases like COPD, ILD, pulmonary vascular disease, and obesity, all of these will be more or less similar. But in deconditioning, only the VO2 max or the VO2 peak will be decreased, and rest of the things will be either normal or slightly decreased only. Indications of termination, because that is also very important when you do the test, and as I said, that one of the residents or doctors remain when the CPET is done, because to analyze when to stop the test and analyze when the risk has increased or the patient can deteriorate further or get admitted in the ICU too. So chest pain suggestive of ischemia ECG changes, ECG is constantly monitored, complex atopy, second or third degree heart block, fall in systolic pressure, more than 20 millimeter of mercury from the highest value during the test, hypertension, systolic more than 250, and diastolic more than 120, severe desaturation less than 80%, sudden pallor, loss of coordination, mental confusion, dizziness or fainting, and signs if there is signs of respiratory failure. So that was all which I tried to complete in few slides. Exercise test is a very vast topic, and each topic itself is a very big thing to discuss. So thank you so much, Pulmocon, for giving me this opportunity to stand in front of you and discuss and share my views on this exercise test in pulmonary hypertension.
Thank you. Thank you, Dr. Kanishka Kumar, for an excellent presentation. Now, we are running short of time, so I am supposed I am having another 5 minutes in my hand. So, somebody for two-chair test, Mr. Rick Chakraborty, I think you can wrap up very quickly so that we can have an expert panel opinion about what we all read from the ENT, from the vaccination, from the bronchiectasis, pulmonary exercise test, we can have an overview and we can have some take-home messages.
Good morning, everyone. Today, my topic of discussion is a two-chair test from inception to execution. It's a very new test, so the two chairs are required to perform this test, and hence the name was coined. So I will move forward with what is two-chair test, how it is done, what needs to be recorded, how and what are recorded, and what can be interpreted from two-chair test. So, in our previous presentation, we have already heard about most of the exercises like 3-step test, 6-minute walk test, 12-minute walk test. Two-chair test is a relatively new exercise in this field. So, what is two-chair test? It's a submaximal exercise which records post-recovery changes in terms of pulse rate and saturation. It records cardiopulmonary reserve specific data. How we do a two-chair test? It's a very simple test. For that, we require two chairs facing each other at a 5 feet distance. A person who is undergoing the test needs to sit at chair A and rest until his pulse rate and saturation stabilizes. Once it stabilizes, we record the data, which serves as the base data. Then the person needs to stand and move to the next chair, sit there, stand, and move back to chair A. Likewise, he needs to make 5 movements. And once he sits, we record his pulse rate and saturation change for the next 2 minutes for every 10 seconds. And this is what we get. This is the record of the data for every 10 seconds. Likewise, we have a graph in which the blue line shows the changes in PR, that is pulse rate, and the red line shows the changes in saturation over this time period of 2 minutes for every 10 seconds in the time series. And there we have like a brief of the results, which shows maximum desaturation and maximum pulse rate change in this duration. Now there are questions which can't be negated, like why 5 movements? So we had like 6 minutes at that time, and we interpreted the results, post-saturation and pulse rate changes with 6 minutes, and this movement, 5 movements data tallied best with the 6 minute post-saturation and pulse rate change. This again, since it's a new test, this proves the reproducibility of the test. Once again, you can see these clusters shows a Pearson correlation of 0.99, which again proves the reproducibility of the test. Now, there comes a question, what are the basic differences between 6-minute walk test and two-chair test? There are a lot of differences, I can read it out, but the basic differences comes in the form of the nature of the test. A 6-minute walk test is a self-paced test. It records the functional activity. There is time limit. But in case of two-chair test, there is no time limit. The patient can go for the test, and it is cardiopulmonary response specific. In case of logistics, 6-minute walk test requires a very long space or a corridor to perform the test. But in case of two-chair test, it can be done in the doctor's chamber itself. And for the other requirements like emergency requirements, these are the same for both the tests. Now this is the paper we have published. You can look into this one. So what were the variables that were studied during the test, and which came as the best container to best tool to appreciate the results? We had basically 2 variables, post-exercise pulse rate change and post-exercise saturation change. Under this there are various variables like minimum pulse rate, maximum period pulse rate change, cumulative pulse rate change, duration of tachycardia, minimum saturation, maximum desaturation, cumulative desaturation, and duration of desaturation. Out of which to determine which was the best parameter to assess the results, we performed a correlation matrix between all the variables, and this set max came as the winner, and this shows highest correlation with minimum saturation in this case. We tried assessing desaturation in different disease groups for different desaturation degrees of desaturation, and this is the data you can see. We have like asthma, COPD, GPLE, and miscellaneous. Miscellaneous group consists of all the patients who are not in these three groups, that is asthma, COPD, and GPLE. In case of desaturation, you can see these are the basic desaturation data for these disease groups, asthma being the lowest and DPLD being the highest one, with the maximum desaturation. We also tried assessing correlating various factors with desaturation. Here we can see there is a good correlation between ACT and desaturation in various degrees of desaturation in case of asthma patients. Similarly with CAT, you can see there is a good correlation. In case of ARS or in case of DPLD patients, there is also a parallel line and it shows a good correlation. And in case of miscellaneous patients, we had another patient perceived score in which we provided them with a Likert scale, and the patients, according to their own perceivedness of sickness, they scored there. And with that, we correlated the desaturation, and it showed a steep line. Now, at the end, what are desat max and 6-minute walk distance? So we have tried plotting them, and you can see that there are absolutely no correlation between them. So it suggests you that probably these are two different tests. In conclusion, I would like to say, 2-tier test records the pulse rate response and saturation response. This is an intervening field, and we are finding intervening data. Probably we will be able to talk more in the next year probably, and we will publish data on that. So, thank you.
Thank you. Now, after a presentation from all the speakers, may I call Professor Pranav Mandal on the dais and all the speakers on the dais. First of all, I would request our expert panel, Professor Pranav Mandal, to just briefly and summarize the topic. As a pulmonologist, what do you think when the ENT consultations are to be taken?
If you think the respiratory system is a two-story building, then the upper floor is maintained by the ENT specialist and the lower floor by the pulmonologist. So there is a concept of one airway, one disease. So there should be expertise, there is exchange of expertise between the pulmonologist and the ENT specialist. Especially when there is unexplained dyspnea, when there is hemoptysis, when there is hoarseness of voice, when there is sleep apnea, and when there is unexplained cough for a long duration. In this particular situation, there must be exchange of expertise between a pulmonologist and a ENT specialist.
Yeah.
Regarding the bronchiectasis, basically the bronchiectasis patients are very miserable. Miserable in the sense, sometimes the expectoration that is treated with bad smell, they are rejected by their families, rejected by their, especially the women, rejected by the families, rejected by the society, and they are very reluctant or very afraid to go anywhere with their problems. But when we search for there is a long list of causes of bronchiectasis. Basically, it is the end result of a continuing insult to the airways. So, and some patients are terrible with the repeated hemoptysis, repeated admission, repeated hemoptysis. So, in this particular area, just tuberculosis, like infective causes like tuberculosis, the search for a specific cause of bronchiectasis should be done, but I think how much it would be helpful to just contain or to decrease the symptoms of the patient because but in each and every cases, we have to search for a reversible cause, treatable cause. Third, vaccination. Adult vaccination. There is universal immunization vaccination in pediatric age group, but there is no such recommendation in adult group. Basically, when the adults are vaccinated, one, just to build up the or increase the immunity, failing immunity of a vaccine which was given in the childhood. Number one. Number two, new vaccine. Number three, some particular group of patients, that is COPD, asthma, heart disease, lung disease, hepatic disease, patients with immunosuppressants, and hematopoietic or transplantation patients. This particular aspirating patient, this particular patient, we give vaccination. As a pulmonologist, we are basically dealing with mainly two vaccinations, influenza vaccination and pneumococcal vaccination. Influenza vaccination, quadrivalent variety, two types. One is live attenuated, one is killed. Live attenuated, intranasal, and the kill vaccine, intramuscular. Yearly. And this live attenuated should not be given to an immunocompromised patient and not to pregnant mothers. But influenza vaccination should be given yearly to COPD patients, asthma patients with chronic lung, liver and heart disease patients with diabetes, alcoholism and smokers also, who are chronic smokers. Influenza vaccination should be given yearly. Regarding pneumococcal vaccination, there is two varieties, conjugate vaccine and polysaccharide vaccine. The conjugate vaccine is more potent. There is a immunologic memory, T-cell mediated immunity, but it's expensive. But in case of polysaccharide vaccine, 23 serotypes are covered. It is B-cell mediated vaccine. Immunological memory is less. As the time goes, there is decrease in immunological memory. But each and every patient above 65 years, you should give pneumococcal vaccine. When you have to give two vaccines, two variants, then always first give conjugate vaccine. Then after 6 to 12 months, the polysaccharide vaccine. If one vaccine is given, that is polysaccharide vaccine, then give one vaccine, no boosting effect after 5 years or 10 years. Sometimes it is given every 5 years, pneumococcal vaccine. Every 5 years, from the age of 30. So, no, just one after 65. And in case of if in some clinical conditions, I have already mentioned, that is immunocompromised, COPD, asthma, heart disease, liver disease, you can give the pneumococcal vaccine below the age of 65 years. If PCV13 not given, then one dose of polysaccharide vaccine to be given and another dose of conjugate vaccine after 65 and second dose of polysaccharide vaccine after 5 years of the previous dose. And polysaccharide and this pneumococcal vaccine is conjugate vaccine, the gap should be 6 to 12 months. So, this is the vaccination strategy. And regarding exercise test, it helps know the work efficiency of that particular person, the disease burden, and also most important is prognosis. From the performance exercise test, you can predict the mortality of the patient also. That is very important, especially in COPD patients. So, we have gone through very excellent and academic lectures to our eminent speakers, and this is my comment regarding my appreciation and their presentation. Thank you, everybody.
Thank you. Once again, I give a last year that as we have guests from all parts of India, north, south, as well as our state. So, do they have any other questions to ask to each other? If they can, if you can ask to for vaccination or if someone wants to, so you can have some interaction within to ask, or else I am going to close this session. Nothing like that. But one thing, what I asked to ask you about the bronchiectasis, I think curative treatment is very much we should think of it, because whatever we are going for a diagnostic work and algorithm in our part of country, first finance is a big issue, second is accessibility. So as far as CFTR, sweat chloride and all those things that really looks very sound theoretically, but I don't think 70 to 80% of our patients can't afford to do that. So if we get a localized bronchiectasis, and if the patient is symptomatic, I think surgical option is the best treatment. It is 8 to 10,000 is okay, fine, but the accessibility, where it is done, and it becomes a very cumbersome procedure for the patient to move. And the most important part, patient will ask us that, sir, what will happen if these genes come positive? What you are going to do? Why I am going to? Because why, but if will come. When I am asking for an HRCT chest, I can explain them that I am going for a diagnosis, to plan for your treatment. I am going for a pulmonary function test with DLCO. I can ask for which type of inhalation therapy we are going to get. If I am asking for a pheno, I can explain them. Now, if I tell them I am going for a CFTR gene, I am going to diagnose the disease, and ultimately the outcome I cannot say whether that can be completely cured or not. And I don't think most of our patients, I can convince at least. What the other panelists say, I don't know. I think convincing them becomes a very big issue. That will be a very nice thing. Now coming to Sivarashmi, I want to ask you that, say, in which types of COPD groups you will be considering the TDAP vaccines?
The thing is, this study that I was showing, the literature survey, that particular study where they found the patients having pertussis in adults, these were young adults, young COPD patients between their 45 to 55 years age. These were the ones who had actually developed, and also smokers. Yes. So that is why these are patients you should target for your TDAP vaccines.
So one thing I would like to ask you that from our childhood we are all vaccinated with pertussis. So if I consider a vaccination, why should I consider this vaccination in the adult? Just to increase the memory cells?
Yes, in the ACIP schedule, I could not actually, because in the interest of time, I could not actually tell you the details. But it is there that if you have a chronic condition, if you are immunocompromised, then the TDAP vaccine has to be given as a booster dose every 10 years.
That's what. Now coming to Dr. Kanishka Kumar, you have shown very nicely about all the pulmonary exercise tests and all the cardiopulmonary exercise testing. Now my question to you is that other than COPD, ILD and asthma patient, now in patients who are planning for lung transplantation, so how it is feasible for a 6-minute walk distance to get performed? Suppose the patient has been planned for a lung transplantation, so how it is feasible to do that? Which type of exercise test you will advise for them?
Of course, if you're sending the patient for lung transplant, planning to do that, 6-minute walk test will be the ideal test to do at that time. And it very much essential. It's not about the timing of the lung transplant, or you have just decided to send the patient to lung transplant. The patient will be following up. If the patient is in interstitial lung disease, he or she will be following up, and you will be constantly monitoring the patient and seeing the improvements or the deterioration time and time again. So if there is a significant fall in the distance, then of course you can plan for lung transplantation. And if there is a slight improvement, but still away from normal, then you can continue with the medication. And you have to keep in mind other factors such as economic status and the age of the patient. And if you have a diagnosis in ILD and suppose CTD, ILD, or can be or hypersensitivity pneumonitis, then you can plan to continue the medical management also. So it's a very diverse topic. It should be discussed with the patients. Especially all the ILD patients should be given a lot of time, a lot of counseling needs to be done, not only to the patient but also to the relatives, and understanding their physical as well as mental and as well as social state. So it's a very complex thing, but should be handled with a lot of care and a lot of time needs to be given.
Thank you very much. To end the session, I will ask our senior sir. Sir, this obstructive sleep apnea comes under whose year of treatment? It comes under ENT or it comes under pulmonologist? Because sir, honestly speaking, the ground truth is that most of the patients comes to us after having an opinion from ENT surgeon, and where the ENT surgeon says that I will do some surgery for you. They have done the surgery and the surgery has failed, they have come to us. Now what to do?
This is a very good question. What I am thinking that mostly it was treated by CPAP, advised by pulmonologist or general physician. What I think that some patients cannot comply with this CPAP, and some are not interested to use it. Again, if there is obstruction in the nose, obstruction in the palate, or any obstruction in the throat, it needs surgical management. Otherwise, how CPAP will work? For which endoscopic assessment should be done, and we should learn the sleep surgery. Sleep surgery is not so easy because CPAP is very good compliance to the patient, because assessment of sleep study or sleep surgery is very difficult, because most common cause is the tongue base thickness. And if this thickness is present, we have to do proper reduction of the tongue base, for which so many operations we are doing, that is radiofrequency application of tongue base reduction of the glossectomy, sometimes advancement of the mandible, advancement of the genioglossus, advancement. Now there is also another technique that is hypoglossal nerve stimulation that helps a lot. For which I think those who are very good compliance with the CPAP is a very common use, but when it is not indicated, like so much upper area obstruction, I think proper surgery should be done. Sleep surgery is a very difficult surgery, and assessment should be done, then we do it.
I think Shivarasmi wants to add something to this.
As a pulmonologist, I would believe that when a patient comes to me and I'm thinking that it is a sleep apnea, my job will be to find out first of all whether the patient has a sleep apnea, whether it's obstructive or central with the sleep studies. Once I see it is obstructive sleep apnea, then the next job of mine will be to look for the reversible factors, whether it's obesity, whether it's an upper area obstruction. If it's an upper area obstruction that needs medical management, I will try that. If it is surgical management, then I will send the patient to the ENT physician, which definitely will give us results. If not, maybe temporary but or permanent, but we can try.
I was very happy when you asked this question. It was a very interesting question. So there are some things in some subjects, some topics where we need multidisciplinary discussions. So, and as we all do, like many centers, at our center we do, when the patients of ILD comes, we have a team of radiologists, we have a pulmonologist, sometimes rheumatologist also, and of course, after we do the biopsy, we have a pathologist also. So most of the time, I have observed that like in 30-40% of the times, when we have not taken the biopsy, we were wrong when we were assuming that it can be HP or CTD. So likewise, in sleep medicine also, we should have a team where we discuss with the radiologist, with the pulmonologist, and as well as the ENT specialist. So how to proceed further in this case, having all the radiology and investigation and sleep study done. So what should be the proper management? And ma'am said that if the modifiable risk factors are there, then we can do that if the surgical intervention is required. So need of MDD should be, it's important and should be incorporated in many, hospitals.
Thank you everybody. It was an excellent session. I thank all my panelists, the speakers, and my expert panel. Thank you very much. I just close the session. Thank you. Okay. Echo. You may
How
do that
exercise-
asthma COPD overlap.
I think
Oh, how to improve the lung function? Okay. That comes under rehabilitation, I think, not in diagnosis.
okay. So
That comes under this.
in pul-
How to increase? Oh, how did that come? Sir, this is what Kanishka said about the exercise test to diagnose the particular disease and its respiratory results and the cardiac results. So what you are asking about what is the outcome of the treatment and how to improve an asthma and the COPD patient exercise.
I think this is a I mean he is asking that how exercise can help to increase the lung functions and lung capacity of the patients of either asthma or COPD. So that's a very important question. After he had diagnosed the disease.
I think it comes from the rehabilitation and your proper treatment.
Yes, of course the FEV1 every non-smoker decreases by 15 to 20 ml per year. So in asthma, it decreases by around 60 to 70 ml per year. So if you foremost thing you have to take inhalers according to the physician. Step down, step up should be decided by the physician. That's a separate thing. But yes, coming on to the corticosteroids which all the asthma patients are taking. So we have to keep in mind the osteoporosis as a risk factor. We have to go for a DEXA scanning in all the patients we are prescribing corticosteroids. And in exercise, yes, pulmonary rehabilitation is a very, very important aspect where many centers have that facilities where you can send the patient, they do pulmonary rehabilitation because sarcopenia needs to be evaluated in all the COPD patients, sometimes by doing the MRI of the thigh also. Sometimes you have to, a dietitian should be there to help them to increase the diet because COPD and asthma is not a disease of only lungs, there are multiple things which is involved and it's a very, very nice question. I think it should be considered off the topic, but it's a good question.
Okay. With exercise, how you are going to cure your deviated
is
nervous
that I think it is not possible. By exercise, you can help this part. It is an anatomical defect. I think anatomical defect should be corrected first.
Hello, hello, hello. Check, check. Hello, hello, hello. 1, 2, 3, 4. Hello, check. Hello, check testing. Hello. Check, check, check. Hello, hello, hello. Hello, check. Hello. 1, 2, 3, 4. Hello, check. Check, check. 1, 2, 3, 4. Hello, check. Hello. Check testing. Hello, hello. Hello, check. Hello. Check. 1, 2. Hello, hello. Check, check. Hello, hello. Check, check, check. Hello, hello. 1, 2, 3, 4. Hello, check. Hello, check. 1, 2, 3, 4. Hello, hello. Check, check. Hello, 1, 2, 3, 4, 5, 6. Hello, check. Hello, hello. Check.
who is participating. So, একটা নাম এগুলো লিখতে হবে। বলো। আমার একটা হোয়াইট কাগজ আছে? প্লেন সাদা কাগজ? প্লেন সাদা কাগজ আছে? A4 paper, no? Oh, A4 नहीं है. अच्छा, but how many teams are there? How many teams are there? 5. Team number? 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Okay. So, what we are going to do is, we have, huh? কিসের জন্য? কুইজের জন্য তো? ও, কারণ নেই। কজন আছো তোমরা? কুইজ নাম বলো। না, কোন কলেজ? মেডিকেল কলেজ। সো টিম নাম্বার 1 মেডিকেল কলেজ কলকাতা। কে আছো টিম মেম্বার্স? পার্থ মন্ডল আর সিদ্ধার্থ কি? আচার্য। ওকে, এটা তোমরা হ্যাঁ তোমরা আর তোমরা এমসিকে পালমো মেডিসিন টিম নাম্বার 2 এমসিকে চেস্ট। বলো কৌস্তব। হ্যাঁ অয়ন গাঙ্গুলি। So you are team number 2. আর কে আছে? IQ City Medical College Durgapur Promoshi Poddar Shoumo Bishwash okay আর NRS MCH SAQU okay আর কেউ? Team number 5 RGKMCH কি? সাদাম হোসেন RN রনিত চক্রবর্তী ওকে। SDMH জয়পুর। আচ্ছা আমাদের 6টা টিম হয়ে গেছে। আমরা 30টা কোয়েশ্চেন এদেরকে দিয়ে দেবো। এটা 30টা কোয়েশ্চেন দে উইল পুট देयर आंसर्स। आंसर যেগুলো আছে না ওগুলোকে হাইড করে দে আপাতত। হাইড তাহলে কি করে? কিন্তু এটা লিখবে না তো। না আমার বক্তব্য হচ্ছে এটা তো আমরা এলিমিনেট করছি। We are giving all 30 questions to all of them. All of them will answer the 30 questions. So your answer গুলোকে হাইড করে দে। We can show that later. Because ওটা তো আমরা 4 জন ভেবে চলেছিলাম। STMH जयपुर डॉक्टर भानु प्रताप सिंह सोलंकी। हाँ और दूसरा यू आर अलोन गुड एक ही काफी है। এই 7টা হয়ে গেল। हेलो राघव। Oh very nice good to see you. Team number 7 CNMCH সায়ন্তন সামন্ত ওকে। বিয়াশিনী Dash. Okay. Aro. Oh, good. Hey, Dada. 8টা team. Huh? Two per team. You can be one also. Shagor Dattu. Dada এক সেকেন্ড দাঁড়া বল থ্রি পার্টি করা যাবে না টু পার্টি আচ্ছা নিয়ে একসঙ্গে নিয়ে চল বল ডক্টর কুণাল ধর মনোজিৎ মুখার্জি ডক্টর আব্দুস সামাদ গুড আরো কেউ এসছে বলো এসএসকে নটা কোথায় 4টে হচ্ছিল না এখন 9টা হয়েছে বলো বল এসএসকে তারপরে আনসার ওই সময়টা আমরা কারেকশন করবো তারপরে ঠিক আছে বল বাহামিক WAMIQU QU गौतमन D अच्छा तुम लोग एग्जॉटिक नाम लाए हो नहीं आर के बचे आर क्यों नहीं बाबा বলো ভুবনেশ্বর কোথায় এই ভুবনেশ্বর কোথায় আইসো কি কি হসপিটাল আইএমএস সাম্বর কোথায় আইএমএস মুম্বাই SUM हॉस्पिटल भुवनेश्वर बोलो पौलोमी शेन राघवेंद्र गुड that's fine so we'll take some time take your time So while Dr. Organised is handing out, so while he's handing it out, let's get a little bit acquainted. So welcome to the elimination round. Elimination round of the national Pulmocare is an annual feature for a number of years now, and very, very good to hear that so many of you are so enthusiastic and dedicated despite the NAPCON going on as well. So that's good. And this afternoon, we are Dr. Organised, Dr. Raghav and myself. We want to talk about together. Good. So we are going to be the quiz masters and scorers. So today is an elimination round and we want everyone to have the same chance to get into the final round. So therefore, what we have done is, we are going to give you 30 questions, which are all MCQs. Okay? So it will be multiple choice questions, 30 questions. You have a sheet in front of you. You will be writing the answer or the option that you think is most appropriate. And you will put it on there. You can consult with each other, but try not to peek into somebody else's, okay? Because you will be losing your chance. And we will give you 5 seconds for each question. Okay? 5 seconds for each question. Is that enough or you want more? Okay. I was very surprised to see you all guys said, okay, 5 seconds is enough. So we will give you 30 seconds for each question. And in those 30 seconds, you will... Oh, we have one more team. Great. So 11 teams. So 30 seconds for each question, 30 questions to everyone, same questions to be answered by each of you. And at the end of that, while Dr. Organised shows you the answers, we will tabulate it. Okay? We will then tabulate which, out of the 11 teams, which 5 teams qualify for tomorrow. So out of 11, 5 teams will qualify for the final rounds tomorrow. Alright? So it's a very fair elimination round. 30 MCQ questions, 30 seconds for each question to be answered on the sheet of paper you have, and then we tabulate and see. In case we have more than 5, then we might do, for the last 2, we might do a tiebreaker. Okay? Question. Only the option. So you will write the question number and option. Yeah.
But ultimately, it comes down to writing a number.
Can we use this as a rest?
We need 2 more pieces of paper. So yes, I'll tell you. Let everyone settle down. I'll tell you. So for the elimination round, we will not have any negative marking. Okay? So it is good enough for all of you to attempt every question. It will either be right or wrong. Negative marking will be for the final round tomorrow. Today it will be +1 and 0. Okay?
End of the quiz, when we tabulate, if 2 teams are at tie, 2 or 3 teams, so the team which has scored less negative, there is no negative marking, but which has scored less negative, they will be out of the competition. Who are less negative, they will be promoted for the final round.
We had been told there would be only 4 teams apparently, and now we have 12 teams. So we have limited number of questions for today.
Hello? Hello? Everybody is ready? We'll start the quiz. May we start? Okay. So we have 30 questions. For each correct question, you will be one. For there is no negative markings. At the end of the tabulation, if there is a draw, then the team which has answered less negative questions, I mean answered less number of incorrect questions, they will be promoted for the next round. So first question for all. Which is the chief constituent of pulmonary surfactants? Options 1, DPPC. Option 2, DOPC. Option 3, DPOM. Option 4, DPCC. 60 seconds. 30 seconds. We are going for the next question. Question number 2. Which is the functional unit of lung as per HSCT terminology? Asinus, secondary pulmonary lobule, primary pulmonary lobule, or terminal respiratory unit? So now we'll move to the question number 3. Who conducted the first lung transplant and also the first double lung transplant in world? We have 4 options: Dr. P.J. Barnes, Dr. J.D. Cooper, Dr. Christian Barnard, or Dr. Robert Bartlett. Next question. Hammond's crunch is synchronous with which of the following physiological phenomena? Inspiration, expiration, deglutition, or heartbeat? Hammond's crunch. Next question, question number 5. Which organism is responsible for a phenomena called known as pseudohemoptysis? The options are Burkholderia cepacia, Pseudomonas aeruginosa, Serratia marcescens, and Mycobacterium chiloni. Which want to know about pseudohemoptysis? Question number 6. Lambert-Eaton syndrome is associated with which cancer? Small cell lung cancer, squamous cell lung cancer, pancreatic cancer, thyroid cancer. Lambert-Eaton. Keratin pulse is found in which lung cancer? Squamous cell, small cell, adenocarcinoma, or neuroendocrine tumor? Good prognostic markers in sarcoidosis are all except HLA-B8 positivity, acute uveitis, strongly positive gallium scan or erythema nodosum, which is not a good prognostic marker in sarcoidosis among these 4. জানলে except দেখিয়ে ফেলবে। Question number 9. All are true for alpha-1 antitrypsin deficiency disease except inheritance is autosomal dominant, a single base exchange is the underlying defect, chest X-ray show basal hyperlucency, emphysema is pan-acynar type. Which of the following is not true for alpha-1 antitrypsin deficiency? We will go to question number 10. All are true for pleural effusion. There is a spelling mistake, sorry for that. Tend to be transudate in mixed syndrome, maybe Kailas in lymphoma, and elevated amylase is diagnostic of acute pancreatitis, have a low glucose content in rheumatoid arthritis related pleural effusion. All are true except, so we want to know which is not true. Easy question but a little tricky. Frequency of sleep waves in increasing order. Delta, theta, alpha, beta, beta, alpha, theta, delta, alpha, beta, theta, delta, theta, alpha, delta, beta. So we want to know the frequency of sleep waves in increasing order. Frequency will gradually increase from 1 to 4. In that case, which option will be correct? Which is false in volume control ventilation. Tidal volume is given according to a preset volume target. If the inspiratory time, number one option is tidal volume is given according to a preset volume target. If the number two is if the inspiratory time is fixed, the peak and mean airway pressure is independent of pulmonary compliance. If the minute volume and frequency is set, it is not possible to adjust the tidal volume. If peak pressure increases beyond the alarm limit, tidal volume will fall below the set volume.
So you have 60 seconds for this.
You read it carefully and answer. So question 13 is another question about positive end expiratory pressure. Here we want to know which is true. In severe ARDS, a PEEP of more than 15 centimeter of H2O improves mortality. Positive end expiratory pressure increases functional residual capacity. Hepatic and renal blood flow is increased with higher level of positive end expiratory pressure. Positive end expiratory pressure application increases pulmonary artery pressure, diminishing venous return to left heart, causing hypotension. These are the four options. Which is true among them? Just read carefully. This is also a very easy question. 1 minute. To increase oxygenation during intermittent positive pressure ventilation, all of the following are useful. This you can call a volume control ventilation or pressure control ventilation. These are increase the FiO2, increase the PEEP, decrease the I ratio and increase the peak inspiratory pressure. Which of the following does not increase oxygenation in during a assist control ventilation mode? Or intermittent positive pressure ventilation. না আপনি কতগুলো কোশ্চেন করুন ওখান থেকেই করতে পারেন একই কোশ্চেন আছে একই কোশ্চেন আছে কিছু চেঞ্জ হ্যাঁ আমি চেঞ্জ করে দিচ্ছি Next question.
Okay. So question 15, no? So all the diuretics, when they are abused, cause metabolic alkalosis except indapamide, acetazolamide, metolazone, and option 4, chlorthalidone. Simple question, simple answer. 5 seconds if you know it. Next question, number 16. So you all have seen this graph quite a lot, the pleth graph versus the flow graph. Which of this represents chronic airflow obstruction when you see it?
Now you have to write 1, 2, 3, 4 or 5, the number on.
Yeah. So see each shape, whichever you think represents chronic airflow obstruction, write the number against it.
Next.
Next, question number 17. Increased bowel eosinophilia is seen in all of the following. I'll just modify it. Can be seen in all of the following except number 1, chronic eosinophilic pneumonia. Number 2, acute interstitial pneumonia. Number 3, cryptogenic organizing pneumonia. And number 4, tropical pulmonary eosinophilia. So to avoid controversy, is nahi, can be seen.
Answer will be that which is where it is never seen.
Yeah. Next question, number 18. Pleural pressure is most negative at number 1, apices, number 2, mid-zone, number 3, lower zone, and number 4, none of the above. This is from our MBBS days. Okay, so next is number 19. How many CD1A positive cells should be present in bowel in the diagnosis of PLCH or pulmonary Langerhans cell histiocytosis? More than 3%, more than 4%, more than 5%, or more than 6%? So next is a question number 20, a CT cut of one of our patients who presented with skin tags on the neck and face and acute chest pain and this CT. And one additional history I'll give you has a family history of recurrent pneumothorax also. So what is the diagnosis?
You're making it too easy.
One easy question for them.
There are a lot of easy questions. This question you must know during your MD days.
Yes. No?
You name the condition.
Name the condition.
Here
So
we
just
have
name
not-
the condition.
Here we can confuse you with options. We have not confused you with options. Give you the chance to write a name.
Because if you know it here. You don't need options. Okay. Next question. In here again, you have to write, okay? In which lung zone is the pulmonary capillary wedge pressure ideally measured?
Zone 1, 2, 3, 4.
Zone
Zero.
1, 2, 3 and 4. So which zone? Okay. So next question. This one also you have to write.
The name.
Which toxin produces Silophyllers disease. You have to write which toxin that produces Silophyllers disease. Write the name of the toxin. Clue, they work in heavy chemical plants. We get some of the patients from Huldia. Can't give you any more clues after this.
It is not making it easy, man. It is making it difficult.
Okay, Arindam, you go.
Which of the following is not true for thoracoscopic cryobiopsy? You obtain a larger tissue sample, you have less crushing artifact in your sample, you have better diagnostic yield, and there is no increase in mild to moderate bleeding risk. Which is not true among these four options when you do a cryoprobe assisted biopsy during thoracoscopy? I hope all of you have seen cryoprobe. I request Jacob to answer the remaining questions. Come here.
Question number 24 about resurrogate, which one is true? It is a stimulator of guanyl cyclase, inhibitor of guanyl cyclase, stimulator of cyclic GMP, inhibitor of cyclic GMP.
There's lots of smiles.
Last 6 questions. Which of the following is not true regarding pulmonary veno-occlusive disease? Option 1, there is an increase in mean pulmonary airway pressure, arterial pressure, increased pulmonary capillary wedge pressure, radiological pulmonary edema, or lymphatic dilatation at lung bases. Which of the following is not true regarding pulmonary veno-occlusive disease? 60 seconds.
Yeah, give them 60 seconds for this one to think it over.
Question number 26. Which of the following pattern of calcification increases the chance of malignancy in solitary pulmonary nodule? Diffuse, popcorn, laminated, or stippled? Question number 27. Which is the cell type of scar carcinoma? Squamous cell carcinoma, small cell carcinoma, adenocarcinoma, or a neuroendocrine? Question number 28. Following should improve in a COPD patient who is entering a rehab program. Survival. Option number 2 is an exercise tolerance, improvement in FEV1, or nighttime desaturation. Which should improve in a COPD patient who is entering a rehab program?
tricky, huh, question. So what should improve?
Last two questions. Which of the following sign has best specificity for ABPA? Has the best specificity for ABPA? Central bronchiectasis, gloving finger sign, ham, or fleeting shadows?
Again, the question here is specificity. A lot of these are there. Which one is specific?
Last question. Vanishing lung syndrome is seen in diagnosis of which condition? SLE, IPF, bullous lung disease, diaphragmatic palsy.
So that's the end of your quiz round. Is there any question you want to see again? Question number 11. Can we go back to question number 11?
Sure.
Okay. Question number 11, bolega?
Frequency of sleep waves in increasing order. Delta beta, delta theta alpha beta bole সময় নষ্ট করার মানে হয় না. You see which one is you think is correct? Yeah. So we are going to next question. Okay. 19.
You can have maximum of 5 questions to ask. Otherwise, we'll go back to asking all 30 questions.
Any more requests? We are very lenient. Just we want you to enjoy that quiz. It's not that much a competition. See, we have
Yeah.
to participate and enjoy.
This is a learning exercise,
Ekdam.
recapitulating exercise.
So 3 options are gone, 2 are remaining. Any more question you want to see? চলে ওখানে বসে আছিস নাকি? খুব ফোকাস। চলে কালেকশন করতে হবে ভাইয়া। আরেকজনকে পাবে। He is a আরেকজন পাবে। ডক্টর রাঘব। আমি বলতে নিজে হেড
আরেকজন কাউকে বুঝে দে, তাহলে ছটা হয়ে যাবে, 5 জন। ঠিক আছে।
Any more question you want to see, or we will conclude here? 21. Zone 1, 2, 3 or 4. I can write A, B, C, D. A is zone 1.
After
B is
this,
zone
one more
2,
question,
right hand.
and then we are finished. We will, question number 2. So just show them question number 2.
So anybody who has not asked, he has no option left. Which is the functional unit of lung as per HSCT terminology. এই স্ক্রিনটা অফ করে দিতে হবে। স্ক্রিনটা অফ করে দিন।
Raghav, after this you collect everybody's answer sheets, and then as we go about telling them the answers, we will correct them as well.
এগুলো আনহাইড করবো তো ভাই, আনহাইডটা কি করে করবো? অ্যান্সারটা কোথা থেকে আসবে? এর পরের কোশ্চেন চলে
So how did you all find it? Easy, moderate,
Moderate.
not hard. See, we are lenient people. We'll see how many of you actually go for the tiebreaker question.
अच्छा हाइड करते रहेंगे और आता रहेगा, है ना?
People, na? 12 तो
12টা।
So এখানে so we sit, all of us can sit here. Arindam, you keep telling them the answers, we will start correcting here.
I need 5 minutes, just I am going to.
Yeah. And that's it.
Travel here to the stand here.
Raghav, do one thing. Keep all four after the other. So when he's telling the answer, then you can just correct each one at the same time.
It answer টা ভুল আছে না? This answer is wrong. It should be answer question. Answer में गलत हो रात को 3 बजे बना रहा था इतना नींद आया मुझे ऊपर थे नीचे strongly positive at least.
So Lambert-Eaton syndrome, what did you all write the answer for? Small cell, very good. Keratin pulse? What? What about, what was your scar carcinoma? What? How many said squamous? And how many said adeno? Rest of you didn't write anything. Like 2 people say squamous, 2 people say adeno. So I want maximum answers. Adeno, how many? Put your hand up. How many said squamous? So more people were in your squamous, yeah? Why?
That is a common belief, it's a common sense.
So it is adeno. Remember that always for the rest of your lives. The scar can arise from previous scars, but doesn't mean it's going to be squamous. It's usually adeno. What is the other thing of scar carcinoma? What is the other very important thing once you diagnose somebody with scar carcinoma? Sorry? What? Huh? Lower chance or higher chance? It's already micrometastasized by the time you diagnose it. That is the thing to remember in scar carcinoma. Therefore, PET scans are not good for.
ऐसे करते रहिए कैसे हाइट ना करके चलो वही है मैं नहीं समझ रहा कैसे कर सकते हैं देखो नहीं मैं हो गया 2 मिनट आंसर बने ये करने से क्या हो रहा है ना आंसर को चेक कर रहे हैं कुछ गलत आंसर लिखा नहीं दैट इज इम्पोर्टेंट ये तो 4-5 बार करके नहीं आया रात को बैठ के 3 बजे तक किया फिर 3:30 बजे सुनी वो तो फिर करना नहीं तो 3:30 बजे सुनेगा तो गलत हो ही सकता है मेरा बात ये है गलत हुआ तो डोंट माइंड तेरा हो गया था क्या है क्या है मैंने केस लिखा है नीदा का केस मतलब कितना वार्षिक हो क्या वार्षिक है रेडियल कहते हैं कि रेडियल ट्राई कर रहा है कोई रेडियल घुसा के ट्राई कर रहा है अंडर क्या एडवांस फ्लोर है नॉर्मल फ्लोर ये जो लंग मिशन वगैरह नहीं है ले ले नहीं अच्छा होगा ठीक है हो गया बॉडी विजन मतलब चलो so please the screen hey screen টা দিয়ে দেবেন So we are starting the answers. Answer sheet should be checked and then tabulated. So which is the chief constituent of pulmonary surfactants? Answer is dipalmitoyl phosphatidyl choline. Other three things doesn't mean anything. I just made them up. Option 1, DPPC. Which is the functional unit of lung as per HRCT's terminology is option number 2. That is secondary pulmonary lobule. And this terminal respiratory unit and as seen as their anatomical terms, not regular. Conducted the first lung transplant and first double lung transplant. This is J.D. Cooper. Interesting is that this Dr. Christian Bernard is the person who has done the first heart transplant. 2 is correct. Among crunch, it is synchronous with, ma'am. 3 is 2. 4 Hammond's crunch. It is synchronous with heartbeat. It is 4, ma'am. We are going to question number 5. Which organism is responsible for pseudohemoptysis? It is Serratia marcescens. Okay. 6. Lambert-Eaton syndrome is associated with which cancer? Answer is small cell lung cancer. 1. Small cell lung cancer. Keratin pulse is found in which lung cancer? Answer is 1. Squamous cell carcinoma. Next question, ma'am. Good prognostic marker in sarcoidosis are all except it's a bad prognostic marker, that is strongly positive gallium scan. That is 3. Question 8. Correct answer is option 3. If anybody of you have any doubts, you can ask during this discussion. Question 9. All are true for alpha-1 antitrypsin deficiencies except this is inheritance is autosomal dominant.
What is the inheritance? Huh? No. No. Huh? No. No. You all should have questioned this question. It's autosomal codominant. They both have to be dominant, so it's autosomal codominant.
So when you can, if you tell this autosomal recessive, technically it's not wrong, but the term is autosomal codominance. Both has to be present. But it is not null 1, it is 1, 1. Now the question 10, all are true for pleural effusion except. This is a very easy question. I think everybody should write the correct answer. Elevated amylase is diagnostic of acute pancreatitis. It is obviously wrong because elevated amylase you can found in esophageal rupture with pleural effusion also. So the 3. This is a very simple but a little tricky question.
Yeah. So it was the catch here was it can be positive in, but is not diagnostic of.
Frequency of sleep waves in increasing order. I have to see the answer. It is 1. Delta theta alpha beta. Delta theta alpha beta.
কি যেন জিজ্ঞেস করেছে এটা আবার তোমাদের কত
Oral.
1 এরা কারেক্ট আনসার দিয়েছে
1 correct আছে। The question 12, it is a lengthy question. Answer is very easy. If you read all the lines, then tidal volume is given according to preset volume, that is, it is volume control. But the inspiratory time is fixed. The peak and mean airway pressure definitely depends on the pulmonary compliance. If compliance is low, pressures are high because volume is fixed. Baki, if the mean volume and frequency is rate, it is not possible to adjust the tidal volume. If peak pressure increases beyond the alarm limit, tidal volume will fall below the set volume. That is how the alarm terminating alarms works in a ventilator. For positive end expiratory pressure, ma'am, so the correct answer is 2 for 12. We are going to 13. It is 2 for positive end expiratory pressure. And the answer is positive end expiratory pressure increases functional residual capacity. There is no trial has shown any mortality benefit with using high PEEP. Hepatic and renal blood flow does not get augmented with PEEP, and PEEP application definitely cause hypotension, but this is a wrong mechanism if we utter that. It doesn't cause it through pulmonary artery, rather it causes it through the venous return. So the answer for 13 is 2. We now go for 14. To increase oxygenation during IPPV, all of the following are useful except. So if you increase FiO2, oxygen increase PEEP, oxygen increase, decrease IE, that is increasing inspiratory time. Oxygen increases, but increasing the peak inspiratory pressure does not increases the oxygenation. It is not a recommended method to increase the oxygenation. I think they have interpreted is wrong. I also have a doubt. A decreased IE ratio means your inspiratory time is going to be less.
What does decreased IE ratio do? It causes hypoventilation, reduces the hyperventilation. How will it affect oxygenation? That is the only concept to take away from here. That's why we are bringing up that. So this is something that everyone has been thinking, that if you decrease IE ratio, oxygenation improves. It doesn't. It will cause hypoventilation. Yeah. So that's why peak inspiratory pressure
Does not increase the oxygen.
improve your oxygenation.
If you decrease IE ratio, oxygenation can improve. But all the other things, there are some proof that oxygen can improve. But increasing peak inspiratory pressure will only increase the ventilation. That doesn't guarantee the increase in oxygenation. That is why it is. So now go to question 15. This is the easiest question. Which of the following diuretic does not cause a metabolic alkalosis? Obviously acidophilomide. As everybody knows, it causes metabolic acidosis. So this is 15-2. Okay. Moving to 16. So this is a S raw. Specific resistant, airway resistant in body box. And the graph which represents chronic airway inflammation is number 3. So if you have not seen the chart, you cannot answer it, but if you have seen the chart, it is an easy question. Now 17. Increased bronchoalveolar lavage fluid eosinophily is seen all of the following except. The except is acute interstitial pneumonia. In cryptogenic organism pneumonia, you can have a neutrophilic lavage, you can have a eosinophilic lavage. But in acute interstitial pneumonia, just listen, then you discuss, listen. But in acute interstitial pneumonia, as this is a diffuse alveolar damage, you will always get a neutrophilic lavage. That is the key point in this.
That is why we say it is not is increased, it can be.
It is not mandatory, but for acute interstitial pneumonia, if you get, why it is important? Sometimes in acute interstitial pneumonia, that can actually mimic a acute eosinophilic pneumonia or can mimic a DRESS syndrome. So if you get a lavage, if it's possible to get a lavage and that is showing you eosinophilia, then there is a very high chance that condition is going to respond to steroid. You can actually give a pulse steroid, which is actually not effective if it is acute interstitial pneumonia. That is why this question has been included.
And AIP, if you are able to do a lavage, will always be a neutropenia.
ये concept team है? Number 10, team number 10.
कॉलेज नाम का बोले थे?
ये अच्छा आपका इस्लाम हॉस्पिटल. ये 17 का आपने कौन सा लिखना चाह रहे हैं? Number 3 और number 2?
See, it's not clear, give it 0.
नहीं,
Because
3
we know the
है.
answer.
We are taking it as 3. Okay. Please, bye. Question 18. Pleural pressure is most negative at? Obviously at number 1, that is epiphysis. There are the alveolar highest in size. most voluminous in the pieces. So answer of question number 18 is 1. Okay. Question 19. This is a little difficult question. How many CD1A positive cells should be present in lavage for diagnosis of pulmonary Langerhans cell histiocytosis? Answer is 4%. I think a lot of you have answered the 5%. So that is I included 3, 4, 5, 6 or the 4 options. So 2. Yeah. Nahi. Yeah. This is should be present. Money, if it is less than 4%, it is not. If it is more than 4%, it is always. 5, 6 is not a criteria. Criteria is 4%. Get my point? Kiss me. Yeah, there is a ERS monograph on this. They have specifically mentioned at 4%, and here the Quizmaster decision is final. As I have going with the answer of 4%, you have to bear with me. We cannot change the answer.
20.
It is Bart Hogg Dubé.
I gave you so many clues. I gave you many clues, and I said there was a family history of pneumothorax.
Question number 21. In which lung zone PCWP should ideally be measured? 1, 2, 3 or 4? So the answer is zone 3. There is a little explanation, I am not going in details. That is the ideal place where the PCWP can be measured.
Why? Tell me why.
Bola?
Why zone 3?
That has been explained here.
I'll tell you who has written the correct answer. We can. Chest medicine R&D one. You've written the correct answer. Why zone 3?
They have heated to cut. So this is explanation.
Why do we do it in zone 3? You can do PCWP in any of the zones. But why is zone 3 important?
How it helps? Bola?
Arterial pressure is least there. Anything else? What? Pulmonary artery pressure is more than venous pressure.
No, that is not.
Anything else? You must have, see, when you know why these zones, you have to know why these zones. Because in all the 3 zones, you can put your pulmonary capillary and measure a bench pressure. But why zone 3? What does zone 3 deviates
So there
anatomy
are
show?
2 points you have to understand. What you are measuring by capillary wedge pressure? You are measuring capillary wedge pressure left arterial pressure.
Yes.
So pulmonary venous pressure. So it has to be more than the arterial pressure. Then it will be wrongly measured. And has to be less than the arterial pressure, but more than the alveolar pressure. Otherwise, alveoli will collapse the capillaries, and you will not get the correct measure. So this is the area where you can measure it.
And this is the area where you can actually accurately measure the diastolic pressure from the PCW. From the left
You
ventricle,
can-
it reflects the left ventricular place. That is why zone 3 and not zone 2 and zone 1. Okay? Okay, next one.
So we are going to question which toxin produces cytophilia disease. It is nitrogen dioxide. Man has given a lot of clues, but I don't think it has made it any easier. It is easier.
I say Pulmocare petrochemicals to somebody or petroleum.
Good, they are trying. No negative marking. Question 23. Which of the following is not true for thoracoscopic cryobiopsy? So Raghav do a lot of thoracoscopic cryobiopsy. Larger tissue sample, less crushing effect, better diagnostic aid, there is increase in mild to moderate bleeding risks. So better diagnostic aid, it has not been proven. There is a recent meta-analysis. It has shown cryo give you larger sample, less artifact, and bleeding the mild to moderate bleeding risk doesn't increase. But the diagnostic aid are same in the both the groups. Okay? So 23 is 3. 24. So Rio see what? Which one is true? This is a stimulator of SGC. 24-1, 25. Which of the following is not true regarding pulmonary veno-occlusive disease? Answer is number 2, that is increased pulmonary capillary wedge pressure. Definitely it has increased MAM, so it is including the pulmonary hypertension. Radiological pulmonary edema, clinical pulmonary edema is also there, and lymphatic dilation, lung vessels. So, we will move to question number 26. Any doubt? Any doubt? Yeah. 25. No, it's not CGMP. It is SGC, guanylyl cyclase. Yeah, no doubt. No doubt, no doubt, no doubt. It's correct. I have checked. The easiest, the thing that we must is right is that I have checked it last time. So less chances of me be wrong and you be right. So accept it. And this is 25. I have not adding it again. 26, which of the following pattern of calcification increases the chance of malignancy in solitary pulmonary nodule? It is 4.
Tell us which one.
Triple. Which is the cell type of scar carcinoma? And I think a lot of people have answered it wrong, but it is adenocarcinoma. Yeah? If you go for the definition of scar carcinoma in the Google, you will find it is defined as adenocarcinoma with a plural tag. So it's adenocarcinoma. Now we move to a question 28. Following should improve in a COPD patient entering rehab program, and the answer is exercise tolerance. Survival has not proven to be improved. FEV1 never improves, and nighttime desaturation, it also tends not to improve. So exercise tolerance is the only thing which can improve with a rehab program. Question number 29, which of the following sign has the best specificity for ABPA? And answer, I think most of you know, is ham. Ham has the highest specificity. That is number 3.
What is the full form of ham?
Now we come to the last question. It's a little difficult, tricky question. Vanishing lung syndrome is seen in which diagnosis? SLE, IPA, bullous lung disease or diaphragmatic palsy? Answer is bullous lung disease. In SLE you get a sunken lung, not a vanishing lung. It is sunken lung syndrome.
Everyone has written SLE.
Now I know that the names are very close to one another. So we finished it. Thank you everybody. So now the scores. We will know the scores and whether there is a tie or not. stand up.
Good. Big round of applause, come on. That's a 50 for the Holland. Second team, NRS, Oluha Moulik and Nazris Saki. Very good. Well done. Third team, Archikor, Mohammad Saddam Hussain and Ronit Chakraborty. Very good. And then fourth team is CNMCH, Dr. Shantanu Shamanto and Dr. Diyani Das. Diyani Das. Very good. And final team, SDM Jaipur, is alone, solely, Dr. Bhanu Pratap Singh Solanki. He contested alone. So give him a big round of applause. Well, very well done. So to all the teams, very, very well done. And thank you for participating. All 5 of you will appear in the final quiz rounds tomorrow. And may the best team win.
Tomorrow will be buzzer round.
Yes. Tomorrow will be buzzer round. Tomorrow will be negative marks round.
Negative marks round.
Yeah.
And everybody will have separate questions. So tomorrow there will be a bit of luck. ना हमारे तो থাকতে হবে
মানে কোয়ালিফাই আজকে কোয়ালিফাইং রাউন্ড তো ডাজন্ট ম্যাটার কে ফার্স্ট আর কে লাস্ট এরা পাঁচজন কোয়ালিফাই করে গেছে
and tomorrow it will be lottery who will get which
Yeah.
seat. There is no fast to five.
So
These
you
5
will
people
you will choose your team whether you will be number 1, 2, 3 or 4 and then accordingly you get your buzzer questions.
So everybody who have a poster presentation should proceed upwards. The poster presentation area is in the foyer, just beside the dining area.
Our next session is Clinical Pulse and Direction Case. Our speaker is Dr. Bhanupratam Singh, and the chairperson is Dr. Imran Gupta. We introduce Sir for this session. Thank you.
You will be presenting the case and you will be asked to intervene in between that what to be done, what has been done, like that. So it will be an interactive case for 30 minutes and your active participation will be required for the better flow of the case.
Hello.
Good afternoon everyone. Today we are going to discuss about an interesting case, a patient with fever and bilateral pulmonary nodules. So we had a patient who was a 30-year-old male farmer with the chief complaints of fever, dry cough, progressive shortness of breath since the last 10 days. There was no hemoptysis, chest pain or joint pain. There was no history of any significant comorbidities, no alcohol, smoking or drug history, without any significant family history, and he was recently hospitalized and was on IV antibiotics, and outside scrub typhus IgM report was positive. So the vitals on admission were the pulse rate of 103 per minute, BP, blood pressure of 120 by 78 mm of Hg, saturation of 96% at room air, temperature of 101 degree Fahrenheit. On general physical examination and systemic examination, we do not notice any clubbing, pallor or lymphadenopathy. On respiratory examination, there was bilateral craps, and with other systemic examination being normal. Further investigations, we had a TLC count of 12,000 per MMQ with LFT, RFT normal, urine routine normal, ECG was suggestive of sinus tachycardia. Patient was continued on the IV antibiotics, that is piperacillin, tazobactam and doxycycline, since his scrub typhus IgM was positive. This was the presenting radiology with, as we can see, we have bilateral mid to lower zone nodular opacity in both the lungs, parenchyma. And this was the HRCT chest. HRCT chest also showed bilateral pulmonary nodules in the mid to lower zone basis. This was the report of the HRCT. As we have already seen, there was bilateral miliary opacities in lung parenchyma with small bilateral effusions. How to proceed further?
No. Do you have the X-ray of the previous admission?
No, sir.
But you have seen it?
Yeah.
So has it changed? The opacities were there in the previous admission, during the previous admission?
No, sir. It was progressive.
So I would like to do a sputum test and do a, what is the eosinophil count?
Dry cough, sir. Dry cough. Patient was having dry cough.
Okay. What is the eosinophil, absolute eosinophil count?
It was normal.
It was normal.
TLC was 12,000.
So then I would like to go for a bronchoalveolar lavage.
Yes.
And send our sample for gram stain culture, AB stain, TB culture, and fungal stain, galactomina, fungal culture, all of them, and a gene expert.
Okay.
Or this I'd like to send, and I'll also like to add a serum galactomina.
Okay.
Sir, the nodules, they are mostly in the lower zone, minimum. Otherwise, there is a farm. Scrub can make susceptible for aspergillus, secondary, and he is a farmer also. He is a head exposure.
what we have here is a young male farmer with a short history of fever, cough and dyspnea, no comorbidities, and X-ray chest suggestive of bilateral mid to lower zone nodular opacities. So first we come to the differentials of micronodular opacities. What can be the differential in this condition? Sorry, sir? Yes. Yes, it's a possibility. We can have infections like bacterial, viral, atypical, fungal. Then we can have immunological like sarcoidosis or granulomatosis with polyangiitis. Then we can have vascular causes also. Metastatic lesions can also present as bilateral nodular opacities. Then miscellaneous causes like pulmonary alveolar microlithiasis. So on further investigations, COVID and H1N1 were negative, HIV was negative, tropical fever workup was negative, mycoplasma IgM was positive. So moxifloxacin was added to the treatment as patient was not responding. So after 7
So the mycoplasma responded to doxycycline? Unlikely.
Sorry, sir?
You have already given doxycycline.
Yes, sir.
So mycoplasma is likely to respond to doxycycline?
Yes, sir, but there was progression in his worsening in his clinical condition.
So, this may not be the causative agent.
Yes, sir. Primarily that was not. After 7 days, as we have already seen, this was the presenting radiology. And after 7 days, his chest X-ray was this, showing progression in the nodularity, opacity in the mid to lower zone, as we can see here. This was the X-ray after 7 days. And on repeat investigation, there were increase in the counts, 14,000. Urine routine, LFT, RFT were normal. ANA was negative, blood cultures were negative. And he had a persistent fever with progressive hypoxemia with an oxygen requirement of 5 to 6 liters per minute with O2 mask and not a nasal prongs. So what next can be done?
Have we done the lavage?
Yes. Next, we did the lavage, but it was terminated prematurely due to patient non-cooperation and desaturation. So BAL was taken, but we could not take bronchial biopsy and TBLB. The BAL was sent for AFB smear, KOH and CBNAT, which were negative. The cytology showed no atypical cells. This was the cytology report. So, in a young male with 20 days of fever, dry cough, progressive hypoxemia, radiologically bilateral diffuse nodules, query miliary, slightly raised counts, worsening on conventional antimicrobials. So in this scenario, as we are a TB endemic country, so miliary tuberculosis was a fair possibility. So the first... Sorry, sir. Cryptococcosis. Fungal, yes sir. Yes sir. Yes sir. Okay sir. Okay sir. Yes sir.
Sarcoid also.
Yes sir.
So have we done the ANCA?
Vasculitis?
ANCA vasculitis?
No. Only ANA was done, sir. So, miliary TB tuberculosis was fair possibility, so we started him on the first line anti-tubercular according to the body weight. Meanwhile, his second blood culture was suggestive of Acinetobacter. So, antibiotics were upgraded according to the sensitivity. But his fever was persistent and oxygen requirement. Sir, sir, it's hospital.
For more than 7 days, sir. 7 days.
7 days he was hospitalized at our center. Yes, sir. He was hospitalized for 7 days at our center and he was previously hospitalized too. Yeah. So his fever was persistent and oxygen requirement was also increasing day by day. So low dose steroid were also added considering serositis and all. His condition is still worsening. So fever persisted, progressive hypoxia. And after 20 days, his X-ray was this, showing more radiological progression even after antibiotics, steroids and anti-tubercular therapy. So at that point, patient became more desaturated and he needed PC BiPAP and HFNC support. So he was shifted to ICU. So what next can we do?
Can plan for a surgical lung biopsy?
Yes. So for fever, we did a bone marrow, which was normal, which showed no any significant abnormality.
Miliary TB?
Miliary, yes, sir. Miliary. Infections. In bone marrow. Yes. Then we did a CTPA, and the rationale behind the CTPA was his progressive hypoxia, which was not responding to the. Yes, sir. So on this, as we can see, there was no evidence of pulmonary embolism, but his nodular shadows were increasing on the CTPA. And up to this time, the patient is in ICU on a PC BiPAP, counts normalized, PCT was normal, 15 days of anti-tubercular therapy was already given, but his fever persisted with more worsening of hypoxia. So this was again the following X-ray. Now what we can do further? Should we go for a drug-resistant tuberculosis or any other diagnosis should we consider?
Drug-resistant tuberculosis, so do you need some
So, for tissue diagnosis, now we come to the tissue diagnosis, bronchoscopy and TVLV, as we have further discussed, the patient was desaturated during the previous procedure, cryo, thoracoscopic lung biopsy, and surgical lung biopsy. So,
surgical lung biopsy?
Yes. This was the X-ray of, on the day of lung biopsy. Thanks to our CTVS team, they did a mini thoracotomy window, and without intubating the patient, they only sedated him, and they took a lung biopsy sample through the endostapler, thus creating minimal chances of bleeding. So this was the histopathological image of the tissue obtained. I would like Dr. Arunolog sir to comment on this. Can you all tell what stain is this? And what could be the finding in this? So this is silver methenamine stain showing the we can see here histoplasmosis. This is the histoplasmosis, silver methenamine stain, which is characteristic for fungal. And
recently have a patient of mediastinal lymphadenopathy. So you have started on empirical antitubercular drugs and going on antitubercular drugs, the response was not good. It's a young patient. So in that patient we have done ibastibine. In this ibastibine slides, Dr. Nadim here, so he is also a PA, he has diagnosed histoplasma. And he has responded to antifungal.
So we reached to the diagnosis of acute pulmonary histoplasmosis. We started him on conventional amphotericin B, but after every dose of conventional amphotericin B, the patient used to have a febrile reaction to it, and he desaturated instantly. We even gave him the pre-medication like IV Avil and IV paracetamol, but he did not tolerate the amphotericin B. So we put him on the itraconazole, which showed improvement over the next few days, and he was discharged on itraconazole at a room air saturation of 92%. And this was the follow-up X-ray of the patient after 30 days. So this was the follow-up X-ray after 30 days, showing radiological improvement.
Very good case. Nice case.
Thank you. Theory. So our experience in the last 3 years at our center, we had. Yes, sir. Sir, just. Okay, sir. We had total of 25 cases diagnosed as histoplasmosis at our center. The gender distribution was how was diagnosed?
All were biopsy.
All were biopsy samples from different sites. All the cases, not only pulmonary. There were 23 males and 2 females out of the 25 cases. The mean age was 50 years, with the youngest of 14 years and the oldest being 70 years. There were different sites for the sample, like vocal cord, tonsils, tongue, abdomen, skin, lungs, liver, buccal mucosa, salivary gland, adrenal, cervical lymph node, and unknown sites. I am citing unknown sites because there were some samples which were received from other hospitals and other centers to our hospital, and they were not labeled as from which site the sample was obtained. Now coming to the theory part of histoplasmosis. Histoplasmosis capsulatum, it is a dimorphic fungus with mold in the soil and a yeast in the tissues. The mycelia, it is a naturally infectious form, microcondyal and macrocondyal forms, which reach the terminal bronchioles and alveoli. And these mycelia transform into yeast inside the macrophages and other phagocytes. And in the microgon. That okay. The mycelia transform into yeast inside the macrophages and other phagocytes. And in the laboratory, mycelia are best grown at room temperature, whereas yeasts are grown at 37 degrees Celsius. Coming to the epidemiology, it is worldwide in distribution, first described in Panama in 1906 by Samuel Taylor Darling. That's why it is also known as Darling's disease. In the US, 60 to 90% of people who live around Ohio and Mississippi River Valley exposed to the fungus at some point during their lifetime. So, there are the reported cases from India according to the Randhawa and Gugnani study. a total of 426 cases during 1954 to 2018 and 207 cases from the literature search in the time period of 2018 to 2020. So the regions along the Ganga river basins such as West Bengal and Uttar Pradesh were the endemic pockets in that study. The soil enriched with bird or bat droppings promotes the growth and sporulation of histoplasma. Activities associated with exposure include excavation, cleaning of chicken coops, demolition and remodeling of old buildings, and cutting of dead trees. The pathogenesis, the microconidia, the respiratory, they inhale the microconidia, go into the macrophages in the lungs. The macrophages insert the yeast form, which further goes to the different organ systems, that is lymph node, liver, spleen, adrenal glands, intestine, bone marrow, and the proliferation is halted by onset of acquired cell-mediated immunity at 10 to 14 days. Then there is formation of granulomas, which further fibrose and calcify, leading to calcified mediastinal lymph nodes, and there are also hepatosplenic calcifications are also seen in healthy individuals from endemic areas. And in immunocompromised individuals, this infection is not contained and can disseminate and present as progressive disseminated histoplasmosis. The clinical presentation, it can present as asymptomatic to life-threatening illness, and it depends on intensity of exposure, immune status, and underlying lung architecture. The asymptomatic infection, we can have a finding of enlarged mediastinal or hilar lymph nodes or pulmonary nodules. The differentials for that are tuberculosis, sarcoidosis, and malignancy. The histoplasmosis can present as pulmonary syndromes like acute pulmonary histoplasmosis, subacute pulmonary histoplasmosis, and chronic pulmonary histoplasmosis, depending on the exposure. And in acute pulmonary histoplasmosis, it is usually followed after a heavy exposure to the histoplasma and can present as fever, cough, dyspnea, as we have seen the case right now. In subacute pulmonary histoplasmosis, there are indolent symptoms, and in chronic, it can present as a cavitating disease which can mimic tuberculosis. Then we can have mediastinal syndromes like mediastinal adenitis and fibrosis. And inflammatory syndromes, it can produce rheumatological syndromes and pericarditis or pericardial effusion. Then it can also present as progressive disseminated histoplasmosis in cases of immunosuppressed individuals, retropositive individuals, and those who are taking immunosuppressive medications. Then diagnosis, histopathology, cytology, and antigen detection are most useful for rapid diagnosis in patients with acute pulmonary and progressive disseminated histoplasmosis. Serology or culture of respiratory secretions for the diagnosis of chronic pulmonary histoplasmosis is useful. Yes, sir, urinary we can also. And recommendation for the treatment of histoplasmosis for acute pulmonary, we can give him liposomal amphotericin B along with glucocorticoids for 1 to 2 weeks, then itraconazole for 12 weeks, and we have to monitor the renal and hepatic functions as well. For chronic or cavity pulmonary histoplasmosis, itraconazole in a dose of 200 milligram BD for at least 12 months, and we should continue the treatment until the radiographic findings show further improvement. And for progressive disseminated histoplasmosis, liposomal amphotericin B for 1 to 2 weeks, then itraconazole for at least 12 months. Then in case of CNS involvement, the liposomal amphotericin B is given for a prolonged period of 4 to 6 weeks, then itraconazole for at least 12 months. And these are the recent WHO guidelines for diagnosing and managing disseminated histoplasmosis among the patients PL-HIV. For diagnosis in the people living with HIV, it should be diagnosed by detecting circulating histoplasma antigens. And for initiation, yes sir, plasma antigens. Then treatment of histoplasmosis. First is the induction therapy with liposomal amphotericin B in a dose of 3 mg per kg body weight. For 2 weeks is the preferred treatment for severe or moderately severe disease. And we can use deoxycholate amphotericin B in cases where liposomal amphotericin B is not available. And it is recommended in a dose of 0.7 to 1 mg per kg for 2 weeks. And for maintenance therapy, itraconazole 200 mg 3 times daily for 3 days, and then 200 mg twice daily is recommended for treating mild to moderate diseases. And the timing of antiretroviral therapy initiation, ART should be initiated the antiretroviral therapy should be initiated as soon as possible among people with disseminated histoplasmosis for whom central nervous system involvement is not suspected or proven, and treatment of co-infection with tuberculosis, they should receive TB therapy according to the recent WHO guidelines. And when to suspect histoplasmosis? First, when the patient have an indolent course of disease and there are risk factors or epidemiological factors which can lead us to the diagnosis of histoplasmosis, along with the radiographic features as we have seen the pulmonary nodules, and not responding to anti-tubercular therapy and the routine antibiotic treatment. Then we should consider histoplasmosis or any other. Yes. Yes, sir. Thank you, sir.
Check.